السلام عليكم، أسعد الله تعالى صباحكم بكل خير. أهلا وسهلا ومرحبا بكم في اليوم العلمي السنوي لكلية الطب البشري بالجامعة الليبية الدولية. انطلاقا مما توليه الجامعة الدولية للعلوم الطبية من اهتمام كبير للأنشطة التعليمية التي تعدها من أولى أولوياتها ومن أهدافها الرئيسية التي تطمح من خلالها إلى تحقيق رسالتها العلمية في نشر المعرفة إلى جانب التدريس وخدمة المجتمع ككل. فقد شرعت كلية الطب البشري لعقد يومها العلمي السنوي الأول في موعده، والذي سيعقد أونلاين بسبب جائحة كورونا تحت شعار كورونا إيرا Work as usual، والذي سيتم فيه مناقشة عديد من الأنشطة التي أعدها الطلاب خلال فترة الدراسة، والتي ستكون متمثلة في البرزنتيشنز أو العروض التقديمية، الجورنال كلوب، الديبيتس أو المناظرات، والريسيرش سمري. فلنبتدئ معا أولى فقراتنا اليوم، ونترككم مع كلمة الافتتاح لهذا اليوم مع عميد كلية الطب البشري الأستاذ الدكتور جمال الطهي، فليتفضل مشكورا.
السلام عليكم ورحمة الله وبركاته. بداية نرحب بجميع الحضور الذين اهتموا بالتواجد في هذا اليوم العلمي لكلية الطب البشري، والذي يقيم تنفيذا لما اتفق عليه في المجلس الأكاديمي للجامعة بإقامة أيام علمية لكافة كليات الجامعة. اليوم العلمي يقيمه الطلبة، سيكون عن بعد، وبعض هذه الأعمال موجودة في مقر الكلية. سيتخلل هذا النشاط مجموعة من الأعمال تشمل تقديم عروض مرئية، وقيام الطلبة بتقديم مناظرات علمية، وهذه إحدى نشاطات الكلية وإحدى طرق التعلم في الكلية التي تنفذ بشكل دوري. كذلك سيكون هناك عرض لبعض البحوث، وتكون هناك مجموعة من ورش العمل والمناقشات ما بين الطلبة والحضور أونلاين. فكل من يرغب في المداخلة أو السؤال أو نقاش نقطة معينة مرحب به. نحن فخورون بما يقوم به طلبتنا وما تقوم به الجامعة الليبية الدولية للعلوم الطبية من نشاطات علمية. نتمنى لكم أن تستفيدوا وأن تستمتعوا بما سيقدم في هذا البرنامج، وتحية لكم، ونلتقي في أيام علمية قادمة أخرى بإذن الله. السلام عليكم ورحمة الله وبركاته.
نترككم الآن مع فقرة العروض التقديمية أو البرزنتيشنز تلقيها عليكم الطالبة ملاك الصادق، طالبة بكلية الطب البشري في السنة الخامسة. تفضلي ملاك.
Hello everybody, my name is Malak Sadiq, final year medical student at LIMU, and this is my presentation about COVID-19. The introduction. The major focus of this presentation is the emerging of the COVID-19, how was identified, the interface between health economic system and the infectious disease, particularly in the context of the human coronavirus and the role of the individual behavior in this infectious disease transmission. Important question that we'll be able to answer by the end of this presentation: what's the COVID-19? What's coronavirus? What are the signs and symptoms? What's outbreak pandemic? And what's the RO? Coronavirus are a large family of viruses. They get their name from the crown-like spikes. They can be seen only on their surface with electron microscopy. They were first identified in the middle of the 1960s. The virus causing the disease, severe acute respiratory syndrome or SARS, in 2002 was associated with the civet cats, and the virus causing the Middle Eastern respiratory syndrome MERS in 2012 was associated with dormitory camels. These viruses didn't always but could cause severe disease in humans. The new type of coronavirus causing COVID-19 and cases were first reported in Wuhan City, China in December 2019. Many early cases were associated with the Wuhan seafood wholesale market. It's not yet clear with which animal the new coronavirus is associated with. Coronavirus affect the airway, the breathing passage or respiratory tract. Symptoms can be mild like the common cold, including a runny nose and cough. However, the symptoms can be more severe and can cause, for example, difficulty in breathing. Severe illness was seen not infrequently in cases of MERS and SARS. So far, we know that not everyone infected with the virus causing the COVID-19 has symptoms. Common symptoms are fever, cough, and feeling tired. Some people become seriously ill, for example, the elderly people who have other health problems. In males, the case fatality rate was high, over a third of cases died. In SARS, it was lower, with 1 in 10 people dying. At present, for COVID-19, it's around 2%, which is 1 in 50 people with the disease dying. Respiratory viruses are usually transmitted through either droplet, aerosols, or contact. Droplet, a large particle that travels less than 1 meter. Smaller particle can form aerosols and may travel further. Contact is usually from droplet landing on an object, which are then touched by another person who then touches their eyes, nose, or mouth. The main way the virus causing the COVID-19 seems to spread via droplet. For example, when someone coughs or through contact with droplet on another object, if the eyes, nose, or mouth are then touched. Potentially, for transmission by aerosols, the smaller particle is under investigation. How virus spread inform the measure to prevent it. So, to prevent droplet or contact transmission, washing hand, maintaining the distance from those coughing or sneezing, not touching your hand or mouth can all help to prevent the infection. How was identified? In COVID-19 outbreak, a cluster of cases of pneumonia were first identified. To determine the cluster of cases is an outbreak, they need to be linked to a time, place as they were. 31st of December 2019, cluster of cases of pneumonia of unknown etiology detected in Wuhan City, China. China alert the WHO, the World Health Organization, China Country Affairs. 12 January 2020, China shared the genetic sequence of the novel coronavirus. In this early phase, protocol for the diagnosis and treatment, surveillance, epidemiological investigation, management of close contact, and diagnostic testing were being developed. Pie chart showing the increase in the cases of the COVID-19 over the first 2 months of the outbreak in Wuhan City. As we see in this pie chart, there is increase in the number of cases. But once they start using the protocol, there is a decline in the number of the cases. So, in 11 of February 2020, the virus and the disease it causes were officially named. The novel coronavirus was named Severe Acute Respiratory Syndrome Coronavirus 2, SARS-CoV-2, and the disease it causes COVID-19. Surveillance of the outbreak continued, and with new data, case definition for the COVID-19 were updated. 11 of March 2020, the WHO Director General declared the COVID-19 outbreak is a pandemic. Identification of the genome sequence. Since China was the source of the area of the outbreak, they played a big role in identification the whole genome of the virus, and it was really in very short time. And that helped in early diagnosis of the disease and detection of the new cases. From the genome sequence, we were able to identify the novel region of the genome and also therefore develop new molecular diagnostic tool from that. The role of individual behavior in this infectious disease transmission. First of all, we need to talk about the infections of this disease. We will look at how measure the infections. So imagine population where one person gets a virus and they transmit to 2 people. And each of these people transmitted to 2 people. You can see that the number of the people infected would increase quite quickly in the population. And if each person transmitted to 3, it would increase more quickly. The basic case reproduction number, the RO, is a measure of the spread. It's average number of successful transmission per case when everyone in the population is susceptible. The reproduction number is above 1, case of number would increase. If the reproduction number equal 1, case number are stable on average. Each case give rise just 1 more cases. And when the reproduction number is less than 1, the case number decreases. So it's clearly important to know that the reproduction number for the COVID-19, because it's caused by a new virus, SARS-CoV-2, we can assume everyone is susceptible. We can estimate the reproduction number by looking at the average number of the secondary cases per case. If we can find the chain of transmission, or from looking at how cases increase in the population over time, which is known as the epidemic curve. How does the COVID-19 compare to other infectious disease? The reproduction number is much lower than for infectious, which are known to transmit particularly easily, such as measles, chickenpox. It's similar in range to SARS, Ebola, and seasonal influenza. Another way to measure the infectious is the secondary attack rate. It's a measure of spread or in a specific situation, for example, household. It's defined as the proportion of those exposed to the primary case that develop the disease as a result of that exposure. Unfortunately, there is limited information on the secondary attack rate for the virus causing COVID-19. So the reproduction number is the sum of the secondary attack rate in each situation multiplied by the number of the contact in the situation. People and our health system. Our people, us, is the key point in this whole pandemic. So I'm just going to concentrate at this. Risk communication and community engagement is a critical component of the response to the infectious disease outbreak. What this looks like depends very much on the context and the disease in question. It could range from social mobilization of staff, having face-to-face discussion with the community members at their doorstep, all the way through to large mass and social media campaigns, sponsorship of a public event like football match, or even community theater performance that help describe the risk of catching particular disease and how to protect ourselves and our people. Lastly, the economic health and health system. The infection prevention control. The aim of the infection prevention control in the context of an outbreak of the novel acute respiratory infection such as SARS-CoV-2 causing COVID-19 are promptly identify and treat any suspect or confirmed cases in such a way as protect the staff and the patient in the risk of a health facility. If health facilities become compromised during an outbreak, this can fuel the wider outbreak and impact broader health services to determine the population. Transmission-based precautions. The World Health Organization currently recommends standard droplet and contact precaution are employed for all suspect and confirmed COVID-19 cases. Patients should be isolated and wear masks if they have to transit through shared area. Staff should wear gloves, gown, eye protection, and medical mask within 1 meter of the patient as a minimum. More extensive environment cleaning should be conducted using any of readily available disinfectant and airborne precaution implemented during aerosolized generating procedure. Challenging in implementation. Challenging and implementation exists at all levels of the health system in country without comprehensive national program for infection prevention and control, special training programs, and dedicated staff to implement national guidance. It's more challenging to implement infection prevention control as a part of outbreak preparedness or response. There are also challenges specific to every health facility. The result of the preparedness self-assessment should highlight the key cases to priorities. This could be repeated periodically to monitor the effect of transmission. Lastly, the conclusion. In summary, to better understand the potential for the spread of the SARS-CoV-2 in different geographical and contexts, in the most vulnerable population worldwide, we need to determine the reproduction number, establish the proportion of those infected that develop the symptoms and seek care, find out the duration of the infections and its relationship to symptoms, investigation the main routes of transmission and see if there are any other rare routes, establish the risk factor for infection and severe disease, and identify the risk factors for the super spreading events. All these areas of study plus the natural history and origin of the SARS-CoV-2 are the focus of the WHO research blueprint, which researchers around the world now striving to address. And this was my presentation. Wish you enjoyed it. Thank you.
شكرا لك ملاك. وصلنا توا للفقرة الثانية من فقراتنا وهي الجورنال كلوب اللي حيقدمها لنا مجموعة من طلبة السنة الخامسة. نبدأ الفقرة الأولى مع الطالب أحمد السيد. تفضل أحمد.
Assalamu alaikum. Today our topic is about the surgical site infection, and in this lecture we will discuss the definition of the surgical site infection and its causes, the risk factors of the surgical site infection. Then we will discuss the classifications of the surgical site infection. Then we will discuss the how to preventing the surgical site infection. At the end of the lecture, we will discuss if the surgical infection has happened and the complications starting complication, how to treat it before the complication or after the complication. The surgical infection is a major problem in surgical practice. In 1992, the U.S. Center for Disease Control revised its definition of the wound infection, creating the definition of the surgical site infection. Why? To prevent the confusion between the infection of the surgical incision and the infection of the traumatic wound, accounts for 15 to 25% of the surgical infections, of all surgical infections, and increased cost to healthcare. The surgical site infection defined as an invasion of the organism. Surgical infection defined as the invasion of the organism through tissue, leading to breaking down of the local and systemic host defenses that lead to local and systemic presentation like redness, hotness, swelling, pus, discharge, and so on. And the surgical site infection can be exogenous or caused by exogenous or endogenous. Exogenous, it means from the environment, from the it means nosocomial, and endogenous mean from the patient himself. Here we have a microorganism that that may cause a surgical infection. Like the most common one is Staph aureus, Enterococci, Escherichia coli, and Pseudomonas. Staph aureus counting 90% as what you see here. The risk factors of the surgical site infection. Generally, we have the general risk factors like poor general conditions, like old age patients, obese patient, malnutrition, and some patients have a systemic disease like diabetes mellitus, patient of immunosuppressant patient have an HIV. And the other risk factors, we call it local risk factors like poor blood supply. It could be poor blood supply, poor surgical technique, poor sterilization, foreign body presence or dead tissue, hematoma, hypoxia, hypothermia, and depends on the nature of the operation. If this operation is clean or contaminated, or clean contaminated, or dirty. The classification of the surgical site infection. It depends on the etiology, time, severity, and depth of the wound. Depends on the etiology. It could be primary, acquired from the community, or indigenous source, such as what? That following a perforated peptic ulcer. The secondary one, or exogenous, acquired from the OT, such as inadequate air filtration, or from contamination at or after surgery. For example, anastomotic leak. Then we depends on the time. It could be early, infection present within 30 days of procedure, or intermediate occurs between the first to the third month, or late presents after 3 months of surgery. Then on the severity, we got a minor surgical site infection. Wound infections may be discharge pus or infected serous fluid, but should not be associated with an excessive discomfort or systemic signs or delay in the return home. while the second one is a major surgical site infection defined as a wound that either discharges significant quantities of pus spontaneously or needs a secondary procedure to drain it. It depends on the depth. We have, like what you see here, the superficial incisional surgical site infection involved the skin and subcutaneous tissue, while the deep incisional surgical site infection involved the deep soft tissue that involved the fascia and muscles. The last one that involved the organs and the space, or called the space surgical site infection, that involved the deep organs, any part of organs. The further classification. Further classification could be clean operation. For example, elective surgery, there is no entering, or risk of the infection يكون less than 1.5%. The other one is a clean contaminated. Clean contaminated elective entering, for example, respiratory, GIT, genital urinary tract, or risk of the infection less than 3%. The other one, contaminated operation. For example, emergency or penetrated trauma less than 4 hours, entry to tract with infected bile, urine, for example. Risk of the infection 5%, just 5%. Yeah, 5%. The dirty operation, like abscess penetrating trauma more than 4 hours, pre-op perforation of tracts, or risk of the infection will be from the 33 or to the 50%. The complication of the surgical site infection. The complication of the surgical site infection, like we have a fistula, it may forming a fistula, sinus, sepsis, abscess formation. It may suppress the wound healing and may cause the wound dehiscence. How to preventing the surgical infection from happening? Pre-op, staff should always wash their hands, and patients pre-operative shaving should be avoided if possible, and attention to the theater technique, avoid the hypothermia, and ensure supplemental oxygen in recovery. Operation theater, ensure sterile caps, masks, gowns, gloves used, skin cleaning, gentle tissue handling, absolute hemostasis, appropriate sutures, materials, avoiding dead spaces. Post-op, we got a post-op and antibiotic, appropriate antibiotic and prophylaxis. With antibiotic, do not replace a surgical drainage of infection. Only spreading infection or signs of the systemic infection, just the use of the antibiotic. That's why we use the antibiotics. Antibiotic therapy approach. A narrow-spectrum antibiotic may be used to treat a known sensitive infection, known bacteria. A new antibiotic should be used with caution, and wherever the possible sensitivities should first be obtained. Combination of the broad-spectrum antibiotics can be used when the organism is not known, or when it's suspected that several bacteria acting in this infection and this surgery may be responsible for the infection. The prophylaxis, empirical covering against expected pathogens with the local hospital guidelines. Single shoot IV administration at induction of anesthesia. Continue as a therapy if there is unexpected contamination. Patients with a heart valve disease or proteasis should be protected from the bacteremia caused by dental work, urethral instrumentation, or visceral surgery. If the surgical infection has happened already, how to treat it? The treatment depends on the type of the surgical site infection, but we've got steps. A surgical debridement, we may do a surgical debridement of the wound with suture removed, free drainage, by reopening affected part of incision and the drainage of pus. Fluid, culture sensitivity, and suitable antibiotic. Give the patient a fluid, take a sample for culture sensitivity or not, a suitable antibiotic. Signs of healing. If there is a signs of healing in your secondary suture. This is the reference that I use it in this lecture, and thank you. Now I will let you with my colleague Madeleine Abbar to talk about some studies about the surgical site infection. Thank you.
Assalamu alaikum wa rahmatullah. My name is Madeleine Abbar and I will present the second part of our presentations. I will talk about implementation strategies to reduce surgical site infections. So, abstract background, surgical site infections portend high patients' morbidities and mortalities. Although evidence-based clinical interventions can reduce SSIs, they are not reliably delivered in the practice, and the data are limited on the best approach to improve adherence. Objective: to summarize the implementation strategies aimed at improving adherence to evidence-based interventions that reduce SSIs. Design systemics review. Methods: they use structure form to extract data on implementation strategies and group them into implementation models called 4Es. Engage, educate, execute, evaluate. Result: in the total 125 studies meet our inclusion criteria, but only 80 studies meet EVOCA criteria, which limited the ability to identify the best practice. Engagement strategies include multidisciplinary work and a strong leadership involvement. Education strategies included various approaches to introduce the evidence-based practice to clinicians and patients. Execution strategies standardize the interventions into the simple take to facilitate uptakes. Evaluation strategies assess adherence with evidence-based interventions and patients' outcome, providing feedback of performance to providers. Conclusions: multi-phase implementation strategies represent the most common approach to facilitating the adoptions of evidence-based practice. They believe these summaries of implementations complement existing clinical guidelines and may accelerate effort to reduce SSIs. Introduction: surgical site infections, as we know, it's a global problem associated with increased mortalities and hospital length of stay, hospital readmission, and cost. So the model also has been used to initiate to prevent thromboembolic events and to increase the early mobilities practice among the hospitalized patients, and focus to administrative and clinical stakeholder, and has technical adaptive culture work to foster the translations of evidence into the bedside practice. Methods: data source and search strategies. They search in the PubMed, NPACE, Cochrane Library, WHO's from January 1990s through the December 2015s. Inclusions and exclusion criteria: it's eligible studies included experimental observation studies, randomized control trials, control before and after studies, interrupted time series studies, quality improvement initiatives. So all surgical patient population and setting, inpatient or outpatients, and patients of all age were included. Study selection and data extractions. Articles were selected in the several phases. First 6 reviewers independently screening the title and generated at least potential abstract for inclusions. Second 4 authors was independently reviewed the abstract, identify article for full text review, and read the article for illegalities. Analysis of implementation strategies, they summarize the implementation strategies according the 4 E's as I mentioned before, and these categories were not always mutually exclusive. Reviewers decide on the best fit through the group consensus. Demographic characteristic. Overall 105 studies, 84% were conducted in the high-income countries and 60% in the low-middle-income countries. So they quantified the studies by surgical specialties, 21 orthopedic and 22 cardiothoracic, 13 obstetrician and gynecologists, 23 gastrointestinal, 3 neurosurgery, 2 plastic surgery, and 28 multiple specialties and 13 undefined specialties. Adherence to SSI's preventions. So the most common measures was appropriated use of surgical antibiotic prophylaxis, which reported in 86 of 125 studies, 68%, and 40 of 70% studies conducted in the low-middle income countries. Other preventions like wound care, preoperative bathing, gloving techniques, hair removal technique, and many others. So engagement strategies among all of the studies, 63% described effort to engage frontline staff as an implementation strategies, largely by forming multidisciplinary team. So these photos show infections control and hospital epidemiologists record identified through database searchings was 30,798, recorded after duplicated removal of 9,823, and recorded screening was 2,481, record excluded was 7,342, full text article assessed for illegalities was 375, and studies included in the quantitative synthesis was 125, and the studies that meet EBOCA criteria was 8. Education strategies in the total 65 studies, 54% use some form of staff educations like traditional teaching methods included large group workshop and ground round and other like briefing and debriefing sessions and life stimulations. And these tables show the infections prevention control measures like surgical antimicrobial prophylaxis, 84 of all studies, 125, and 14 in the low-middle income countries. Another example like gloving technique in 10 of 125 studies and 0 in the low-middle income countries. Execution strategies described by 108 of 125 studies, 86% executions often focus to interventions by simplifying and standardizing the care delivery process and creating verification check. Furthermore, 57 studies, 46% implemented protocol, pathway, and policies to improve adoptions of prevention measures. Evaluation strategies of 125 studies, 74 studies, 59% described evaluation activities with a general focus on giving feedback to key stakeholders to support improvement efforts. Conclusions, in this systemics review, they identify 125 studies that described implementation strategies to increase the adoptions of evidence SSI prevention measures. So these strategies aim to build up and encourage the multidisciplinary teamwork to obtain leadership buy-in, to increase the staff and patients' awareness and knowledge about SSIs and preventions practice, to standardize and simplify clinical process, and to create certification procedures, and to provide timely feedback to stakeholders to support improvement efforts. The new research regarding to the SSIs in Benghazi, Libya was conducted in El Jala hospitals by Dr. Uthman al-Tajouri. They said in the background, surgical site infections are the most third most commonly reported nosocomial infections, objective to find out the prevalence of SSI's risk factor implicated, organism involvement, material and methods. So it's a descriptive case series studies and data of 204 cases who underwent surgery in 2019. And the result was the most common organism that cause surgical site infection are Staph aureus. So the recommendations, we should correcting the anemia before the surgery and decrease operations period might be reduced SSIs. So the keyword Al-Jala Hospital, surgical site infections, emergency, Staph aureus, prolonged hospital stay. And these are the references, and thank you so much.
Today's presentation will be about the valvular heart disease and the latest guidelines in the management of patients with valvular heart diseases. It will be presented by me, Wissam Fadl, and Nadia Al-Fitouri. The objectives we intend to cover in our presentation include a brief introduction to valvular heart diseases, its epidemiology, class of recommendation and level of evidence, and then the updates on the guidelines of managing patients with valvular heart disease and the importance of these guidelines. We will begin with valvular heart diseases, which, as we all know, it's a group of disorders characterized by damage to or a defect in one of the 4 heart valves, either the mitral, aortic, tricuspid, or the pulmonary valve. The defect leads to valve failure or dysfunction, which could result in diminishing the heart functionally, although the particular consequences and complications depend entirely on the type and severity of the disease. The term valvular heart diseases covers a large number of disorders that could affect the valves, but the ones that are more commonly focused on include the aortic and mitral valve disorders, or as cardiologists refer to, the left-sided heart valves disorders. These include the aortic valve regurgitation or stenosis and the mitral valve regurgitation or stenosis. Also, the pulmonary and tricuspid valve disorders, or the right-sided heart valves disorders, which include the pulmonary valve regurgitation or stenosis and the tricuspid valve regurgitation or stenosis. Another group of disorders that affects the valves include the inflammatory diseases like infective endocarditis and rheumatic fever. Why are we interested in the management of valvular heart diseases? Well, because it does affect a considerable percent of the population. As this graph shows here, about 14% of the population above the age of 75 are diagnosed with a valve disorder. If we focus on the more common ones, like mitral valve diseases, it affects around 8% of the population between the age of 65 and 74, and around 10% of the population above the age of 75. As for aortic valve diseases, it affects around 2% of the population between the age of 65 and 74, and around 4% of the population above the age of 75. Knowing these numbers, we understand now that the burden of valvular heart disease is heavy on the community, and its management should be taken seriously. And for that, and since 1980, the American College of Cardiology and the American Heart Association have translated scientific evidence into clinical practice guidelines with recommendations to improve the cardiovascular healthcare system regarding valvular heart diseases. These guidelines, which are based on systematic methods to evaluate and classify evidence, provide a cornerstone for the quality of cardiovascular care. These guidelines provide recommendations applicable to patients with or at high risk of developing cardiovascular disease. They're intended to define practice meeting the needs of patients in most, but not in all circumstances, and should not replace clinical judgment. Now, to ensure that these guideline recommendations remain up to date, the data are reviewed on an ongoing basis of an approximately 6-year cycle. The focus of the 2014 guidelines for the management of patients with VHD was the diagnosis and management of adult patients. However, as the field of VHD is rapidly progressing with new knowledge of the natural history of patients with valve diseases, and since several randomized controlled studies have been published, particularly with regard to the outcomes of interventions, Major areas have changed, including indications for surgical management for patients with mitral regurgitation and indications for transcatheter aortic valve replacement. The new and modified recommendations for each clinical section is included in the 2017 focused update of the 2014 guidelines for the management of patients with VHD. How are these guidelines stated? It depends on two parameters. These are the class of recommendation and level of evidence. To start with the class of recommendation, it indicates the strength of the recommendation by estimating the magnitude and the certainty of the benefit in proportion to the risk. There are 5 classes. We'll go over them, starting with class 1, where the benefit is 3 times higher than the risk. When writing recommendations, the phrases used include is recommended and is indicated, and when comparing the effectiveness of treatment strategies, we use is recommended and should be chosen over. While class 2A, where the benefit is 2 times higher than the risk, we use phrases like is reasonable and can be useful. And when comparing the effectiveness of treatment strategies, we use probably recommended and is reasonable to choose. While in class 2B, where benefit is slightly higher than the risk or equal to the risk, we use phrases like may or might be reasonable. And when comparing the effectiveness of treatment strategies, we use unknown or unclear. Class 3 moderate, where benefit is equal to the risk, we use phrases like is not recommended and not indicated. And class 3 strong, where risk is higher than the benefit, we use phrases like potentially harmful or associated with high % of morbidity and mortality. The second parameter used is the level of evidence, which rates the quality of scientific evidence that supports the intervention on the basis of the type, quantity, and the consistency of data from clinical trials and other sources. There are 5 levels, starting with level A, where the evidence acquired is of high quality from more than 1 RCT, or meta-analysis of high quality RCTs, or 1 or more RCTs corroborated by high-quality registry studies. Level B, randomized, is acquiring evidence of moderate quality from 1 or more RCTs or meta-analysis of moderate quality RCTs. While level B, non-randomized, is acquiring evidence of moderate quality from 1 or more well-designed, well-executed, non-randomized studies, observational studies, or registry studies, or meta-analysis of such studies. Level C of limited data is when the evidence is acquired from randomized or non-randomized observational or registry studies with limitations of design or execution, or meta-analysis of such studies, or physiological or mechanistic studies in human subjects. While level C, expert opinion, is when the evidence is acquired from expert opinion based on clinical experience. And now the second part of today's presentation will be presented by Nadia Al-Fitouri.
In the second part of today's presentation, we will discuss the modified guidelines for the management of aortic stenosis and mitral regurgitation, according to the American Heart Association's 2017 updated guidelines. We will cover aortic stenosis treatment, including surgical aortic valve replacement and transcatheter aortic valve replacement. And then I will highlight new guidelines regarding mitral regurgitation, chronic primary and secondary intervention. As we know, aortic stenosis is the obstruction of blood flow across the aortic valve, and it is a chronic progressive disease that mostly affects the elderly. It produces obstruction of the left ventricular stroke volume, which may lead to symptoms such as chest pain, breathlessness, syncope, and fatigue. However, some patients may be asymptomatic. It may be due to either a degenerative calcific aortic valve or a congenitally bicuspid valve, or due to rheumatic heart disease. Firstly, surgical aortic valve replacement. This is a Class 1 recommendation, and it is recommended in symptomatic and asymptomatic patients who meet an indication for aortic valve replacement and whose surgical risk is low or intermediate. The level of evidence has been updated from A to B and R. Prior recommendations did not take into consideration the symptomatic status of the patients, whereas now both symptomatic and asymptomatic patients are encompassed in these guidelines. Both patients show an excellent outcome after surgery, with relievement of symptoms and improvement of left ventricular stroke volume. Whether surgical or transcatheter aortic valve replacement is used, it is recommended for symptomatic patients who are at high surgical risk. The choice depends on patient-specific surgical risk and also patient's choice and personal preference. The class of recommendation has been updated from 2A to 1, and the level of evidence has been updated from B to A. Longer-term follow-ups and additional RCTs have demonstrated that transcatheter aortic valve replacement is equivalent to surgical aortic valve replacement, with the same outcome. Transcatheter aortic valve replacement is recommended for symptomatic patients who have a prohibitive risk for surgical aortic valve replacement. Class of recommendation is Class 1, and the level of evidence has been updated from B to A after random control studies and additional observational studies have shown that there is a benefit from transcatheter aortic valve replacement in patients who were previously deemed inoperable, and showed an improvement in symptoms and reduction in rehospitalization in these patients. Transcatheter aortic valve replacement may also be considered in patients with an intermediate surgical risk. The choice depends on patient preference and specific risk. Class of recommendation is 2A, and the level of evidence is BR in this case. This slide summarises the guidelines for management of severe aortic stenosis. As you can see, patients with low surgical risk are recommended for surgical aortic valve replacement, and this is a Class 1 recommendation. Patients with intermediate surgical risk are recommended for either surgical aortic valve replacement, this is a Class 1 recommendation also, or transcatheter aortic valve replacement, Class 2A recommendation. Patients at high surgical risk are recommended for both surgical and transcatheter aortic valve replacement, both being a Class 1 recommendation. And patients with prohibitive surgical risk are now considered eligible for transcatheter aortic valve replacement, and this is a Class 1 recommendation. The second part of today's presentation will be on mitral regurgitation, which is defined as an abnormal reversal of blood flow from the left ventricle to the left atrium. It is caused by disruption of any part of the mitral valve apparatus, and the most common etiologies of mitral regurgitation include mitral valve prolapse, rheumatic heart disease, infective endocarditis, annular calcification, cardiomyopathies, and ischemic heart disease. The new guideline regarding chronic primary mitral regurgitation is that mitral valve surgery is now reasonable for asymptomatic patients with chronic severe primary mitral regurgitation. This is Class 2A recommendation, and the level of evidence is CLD. In regards to chronic secondary mitral regurgitation, guidelines have now been changed in that patients who have mitral regurgitation due to ischemic heart disease or heart failure, the usefulness of mitral valve repair in these patients is now uncertain. The level of evidence has been updated from C to BR. The 2014 recommendation supported mitral valve repair in this group of patients, but after random control trials showed no clinical benefit of mitral repair in this population. In contrast, it showed an increased risk of post-operative complications. Therefore, replacement in these patients is now uncertain. In summary of today's presentation, guideline recommended management is effective only when followed by healthcare providers and patients also. Adherence to recommendations can be enhanced by shared decision-making between healthcare providers and patients, with patient engagement in selecting interventions based on individual values, preferences, and associated conditions and comorbidities. The focus of these guidelines is on medical practice in the United States, but guidelines developed in collaboration with other organisations may have a global impact. Thank you for your attention. These are our references, and for further reading, we suggest reading the 2014 Guidelines for Management of Patients with Valvular Heart Disease.
شكرا للطلبة اللي كتبوا الجورنال كلوب، وتوا وصلنا للفقرة الأكثر حماسا وهي فقرة الديبيت أو المناظرة. حيكون عندنا موضوع طبي معين وحيكون في فريقين، فريق معه وفريق حيستلم إدارة هذا الحوار الطالب في السنة الخامسة محمد الدراجي. تفضل يا محمد، وحظ موفق للفريقين.
السلام عليكم، أنا محمد دراجي طالب سنة خامسة لكلية الطب البشري في الجامعة الأهلية الدولية. حنكون اليوم نقدم إجازة الديبيت أو المناظرة في اليوم العلمي في كلية الطب البشري. والديبيت أو المناظرة هو نوع من أنواع الحوار بين طرفين أو أكثر، يقوم أطرافها بالتحاور حول قضية فيها إشكالية معينة، ويكون هناك فريق مؤيد وفريق آخر معارض لهذه الإشكالية. يقوم كل طرف بالحوار إثبات صحة رأيه والدفاع عنها باستخدام حجج وبراهين علمية، كما يحاول إقناع الجماهير برأيه وحججه، وأيضا يحاول كل طرف إثبات خطأ موقف وراء الطرف الآخر، وكذلك من أجل الفوز في هذه المناظرة. تدار المناظرات ضمن قواعد وضوابط وشروط معينة تختلف حسب المكان المستضيف في هذه المناظرة وحسب نوع القضية المطروحة. ومن فوائد المناظرات هي توطيد مفهوم التركيز في الحديث والحوار والاستماع والإصغاء، وكذلك العمل الجماعي. ستكون مناظرة اليوم حول بعنوان Can doctors with HIV infection become surgeons؟ وأطراف المناظرة هم طلاب السنة الخامسة، وسيتم تقسيمهم إلى مجموعتين. المجموعة الأولى وهي المؤيدة للفكرة، وهم محمد الصعيدي، خليفة جنيبر، محمد الغرياني. والمجموعة الثانية وهي المعارضة للفكرة، وهم هديل اللافي، سارة جازلي، وهند رفاعي. أترك فرصة للمجموعة الأولى لتقديم الحجة الخاصة بهم. تفضلوا.
So, it's me, Khalifa Gneber, and I'll be discussing the biological aspect of this matter. طبعا, just to be clear, we're not willing to make our opponents change their minds regarding this topic. لكن the idea of changing or exchanging the different perspectives in this topic is itself very good. The other thing is that it's a serious topic, and we're not going to say anything but the absolute truth. Okay, let's start. First of all, what is HIV or AIDS? As we all know, AIDS or HIV is the human immune deficiency virus, which is a type of lentavirus, a subgroup from the retrovirus family. The virus that is responsible for the acquired immune deficiency, which is called AIDS. Its virulence lies specifically in the fact that it invades our immune cells, particularly helper T cells, which is responsible for the activation of almost all the adaptive immunity. HIV differs from other retroviruses in its shape, and also in the fact that it's composed of 2 copies of positive single-stranded RNA, which makes it easy for it to replicate and without forming the messenger RNA and stuff. The other thing is that it's composed of many enzymes in reverse transcriptase, with proteases, with ribonuclease, with integrase, which all participate in its replication and transcription and forming multiple virions that is highly effective. The truth regarding HIV or AIDS is that it continues to be a major global public health issue, having claimed more than 32 million lives so far. The other thing is that 37.9 million people living with HIV at the end of 2080, with 1.7 million people becoming newly infected in 2080 globally. The most advanced stage of HIV is acquired immune deficiency syndrome, AIDS نفسها, which can take from several years to 15 years to develop. بس ما ننسوش نقولوا ان هنا نحن نادين نحكوا على واحد مش واخد اي treatment، قاعدين نحكوا على الطبيعه بتاعنا. هو اصلا he start discovering انه هو infected امتى؟ لما يوصل للايدز هذه، يبدا عنده recurrent infections وكذا، فبالتالي شنو قاعد يشوف يلقى روحه انه هو having HIV or HIV positive. For its transmission, HIV can be transmitted by exchange of variety of body fluids of the infected individuals, such as blood, breast milk, semen, or vaginal secretions of sebum. But for the sake of preventing HIV stigma, individuals cannot become infected through daily life activity, including hugging, shaking hands, even sharing the personal objects, including food and water. For the non-incubational risks of getting infected with HIV, there are multiple things, including unprotected intercourse, having another sexually transmitted infection. Science says when you have another STD, the ability of HIV to shed from the vaginal or penile wall is easier. Sharing contaminated needles, syringes, and other injecting equipments and drug solutions when injecting drugs, and receiving unsafe injections, blood transfusion, tissue transplant, medical procedures that involve unsterile زي piercing. هل هناك cure لل-HIV؟ تمام. طبعا before we start talking about the cure نفسها, the treatment itself is divided into two main categories. في حاجة يقولوا لها sterilizing treatment, وفي حاجة أخرى يسمون فيها شنو suppressing treatment. The sterilizing treatment, as the name indicates, it involves eliminating or eradicating the virus by 100% from blood. تمام. لكن for some viruses or microorganisms that has the ability to invade or become latent, eradicating treatment مش حيشتغل عليها، فيديروا لها بنوع آخر من treatment يسموا فيه شنو functional inhibiting أو suppressing treatment. تمام. بالتالي أنت you convert the virus or microorganism from the active state into the latent state. فهذه بالنسبة للتريتمنت in general. بالنسبة لل-HIV طبعا when it came out it was treated as any retroviral، لكن احنا قلنا انه يختلف عن retroviral other retroviruses. فشنو كان المونو anti retroviral therapy itself didn't work upon it. ان شنو ان في اكثر من enzyme، ولما انت تعطي تشتغل على enzyme واحد ففي other enzymes that has the ability to شنو replicate forming further virions وانت مش هتقدر توقفه. فلذلك CDC in 2016 او WHO تمام they developed a new therapy program يسموا فيه ال highly active antiretroviral therapy، اللي هو يتكون مش من one لكن شنو 3 treatments that could act very effectively، بالتالي شنو has a greater chance of inhibiting or suppressing the virus. تمام. فهذه هي الفكره. وبالتالي patient يكون شنو يكون اول حاجه concentration بتاع الفيروس itself decrease to a level where هو ما فيش حتى is not considered to be affected، لأن ما فيش أي flare up of symptoms أو حتى signs أو أي حاجة. تمام. وخلاص. فلذلك الساينتست thought about إنه شنو ليش ما نقدر شنو طالما إحنا خلاص البيشنت إنه هو ما فيش أي symptoms، ليش ما نحن الحاجة الوحيدة نقدر نديروها أخرى إن نحن نمنع its transmission. فكيف نقدر نديروا الحاجة هذه؟ هذا عليش they developed the so-called اللي هو البروفايلاكسيس. هذا programs هنا اثنين، في واحد يقولوا له pre-exposure prophylaxis program والأخر اللي هو post-exposure prophylaxis program. The pre-exposure as the name indicates إنه طبعا في two main types. في the one that is taken regularly اللي هو 1 tablet per day، والأخر اللي هو يسموه فيه on demand on exposure، سواء كان موضوع مثلا إنه مثلا sexually أو كان موضوع إنه شنو إنه مثلا زي مثلا occupational زي مثلا in our case surgeons. On demand فكرته إنه 2 tablets 24 hours before and tablets شنو 1 tablet 24 hour after، وبعدين تاخذ بعدها بيومين أيوة تاخذ شنو تاخذ another tablet. البوست اكسبوجر prophylaxis زمان was considered as an emergency act. كان الفكره منه انه واحد ما يقدرش يعرف الشخص اللي قدامه عنده ولا ما عندش، لكن شنو مجرد ما يشك او يحس ان الشخص اللي قدامه عنده HIV فيعدي شنو يعدي ياخذه في غضون 72 hours. لكن زي ما حتقول الدراسه اللي تو حنحكيكم عليها كل ما كان اسرع كل ما كان احسن، في غضون 24 hours مرات تكون احسن. تمام. في 2 studies that I brought. One was done by a partner in health. It involved homosexual couples. It's not in our topic, لكن شنو it discusses the transmission itself. تمام. في دراسات أخرى لكن احنا جبنا 2 بس. تمام. أول وغيرها حيقولوا لهم زملائي. first one نفس ما قلنا partner by partners فكرتها شنو إن it involved homosexual couples. تمام. One partner was HIV positive but other was شنو HIV negative. And they were allowed to do اللي يسموه فيه شنو unprotected intercourse. تمام. الدراسة هذه أجريت عليهم كانت تشوف هل السيرو نيجاتيف هذول حيجوا بوزيتيف ولا لا. في حين السيرو بوزيتيف اللي عندهم HIV كانوا ياخذوا شنو في البري اكسبوجر بروفايلاكسيس. تمام. والدراسة هذه استمرت من 2010 لعند 2018. تمام. الدراسة هذه وجدت إن كلهم الناس اللي هم were affected هذول كلهم قريب 948 واحد اظن 972 واحد. تمام. 15 منهم بس هم اللي قدوا الجماعه النيجاتيف 15 منهم بس اللي قعدوا شنو seropositive. When they were يعني genetically analyzed وجدوا ان شنو؟ وجدوا ان السيروتايبس اللي عندهم مش نفس السيروتايبس اللي عند their partners, and once they were asked and يعني investigated it turned out to be that they were cheating on their partners. فلذلك يعني حرفيا ان ما فيش اي نوع من transmission طالما انت خذيت ال pre-exposure prophylaxis program بصفه عامه. لو انت go through it حيجد عندك قاعده يسموا فيها اللي they developed اللي هي undetectable معناها there is no transmission. تمام؟ هذا بالنسبه للفيرست ستادي. The second study which is in our topic اللي هي شنو occupational transmission of HIV اللي هو post exposure prophylaxis program. تمام؟ الدراسه هذه was published by the Public Health England in 2015. الدراسه حاطين الريفرنس بالاخير تقدروا تشوفوها. Between 2004 and 2013, a total of 1478 healthcare workers were reported as having been exposed to patient blood containing HIV in the UK. 3/4 of these took in post-exposure prophylaxis. They were given an emergency actor, and almost all did so within 24 hours, and as early as possible. So it turned out no HIV infection as a result. تمام؟ هذا بالنسبة لل biological aspect of this matter. Now I will allow my colleague Muhammad Al-Riani to finish.
تمام. شكرا خليفة. أنا محمد خليل. لو حنكمل إن شاء الله على زميلي. طبعا كنا نقولوا ليش يعني عدد السيرجنز مش شوية في العالم، ليش نعرضوا البيشنت في خطر وخلوا HIV positive سيرجن يدير لهم في السيرجن. طبعا if that's your point of view you need better information. Today the truth is that it's virtually impossible to catch HIV from someone who is HIV positive and receiving treatment. People living with HIV who are on stable effective treatment will have undetectable levels of virus in their blood. That means blood infecting another person is almost nothing. يعني هم ما همش خطيرين. There have only been 4 cases worldwide of people being infected by a healthcare worker. يعني من الموضوع هذا كله في بس 4 حالات HIV positive surgeon عدا بهم البيشنت بتاعه، وال4 حالات هن كانوا من قبل ما يطلع الدواء هذا ومش ماشيين على النظام اللي نحكوا عليه نحن تو. So HIV infected surgeon can continue practice and perform invasive procedure and surgical operation unless كيف كأي other disease. مثلا أي واحد عنده أي surgeon عنده any other viral infection ولا بكتيريا مش حيدير عملية. يعني هو مثلا ممكن يعدي المريض الآخر أو عنده أي disability كأي مرض آخر. فلوجيك يعني ما فيش دكتور عنده مرض داير له disability or he will infect البيشنت بتاعه حيدير عملية. Okay, the surgeon should know their own status for HIV infection as they would be knowledgeable about any other disease. يعني أنا مش هنخليك وخلاص ونقول أوكي أي surgeon with HIV can do surgery سيبهم. لا، ضروري يدير في الفيرال لود بتاعه ويعرف ضروري يقعد له ويمشي على الكاتيجوري اللي قلناه. So treatment of HIV infection will not cure لكن عنده هو effective و is recommended. يعني عارفين نحن ان البيشنت مش هيصح totally لكن treatment effective و recommended. The HIV level in the blood of those on modern combination drug therapy are too low for virus to be transmitted. يعني لما ياخذ الدواء بتاعه ويجد viral load low will not infect any other patient. People on drug treatment can now live as long as anybody else while a good quality of life with a good quality of life and they will not infect their parents. So the issue is, are people who are infected infective or not rather than are they infected or not. نحن ما نبحثش للHIV surgeon انه هو ممكن يعدي المريض ولا لا. نحن توا بالطريقه الفريق المعارض يبحث انه هو عنده HIV ولا لا، لكن هو اوكي عنده HIV لكن مش هيعدي حد. يعني فنحن قاعدين نشوف انه هو عنده HIV ولا لا غير انه هو يعدي ولا لا، رغم انه هو ما يعديش لو خذ تريتمنت والفاير لود بتاعه. طبعا في precaution ضروري يديرهم كيف any other surgery اللي هن protective eyewear والماسك and water impermeable gowns. Sleeves and boots are standard equipment في أي surgery. Wearing 2 pair of latex gloves reduce the risk of exposure due to the gloves defects from approximately في study بيقولوا ان هن نقصا من 17% الى 5% يقعد الريسك نتاع الاكسبوجر. طبعا اكثر حاجه يتعرض لها السيرجن هي نيدل ستك في الستيتشنج في نهايه السيرجري، وعاده يكون في النون دوميننت هاند للاندكس ولا الميدل فينجر، والحل بتاعنا هو يلبس شيلد فنقدر نقصوا الريسك اوف اكسبوجر. The risk of transmission of HIV to healthcare professional is higher. HIV patient not surgeon HIV patient يعني هم اكثر من عدد الدكاتره اللي عندهم HIV، والسيرجن مضطر انه هو يدير عمليه ويعرض روحه للريسك. لو يجي بيشنت هكاي ما يقدرش يقول لا هذا ضروري يدير العمليه، فبرضه الدكتور قاعد في ريسك. فليش انت حط الدكتور في ريسك رغم انه هو ريسك البيشنت هذا بغض النظر هل الفيرال لود نتاعه الواطي ولا لا لو ولا لا، هل ياخذ في دراج ولا لا، الدكتور او السيرجن مضطر انه هو يدير العمليه وياخذ الاحتياطات اللي قلنا عليها. لكن لما يجي دكتور عنده اتش اي في بيرسون اتش اي في بوزيتيف ليش نمنع فيه انه هو يدير عمليه؟ طبعا فيه الستوري بتاع الان رايت، هذا دكتور قرا 7 سنين وحضر وبدا يشتغل هوكي ودار حوش وسياره بالتخطيط عابي انه هو يعني الفلوس نتاع الشغل نتاعه يدير لنا يسلك بين الفلوس. بعد كم سنه شعر جانا اتاكس فيفر هوكي فدار انفستيجيشن طلع اتش اي في بوزيتيف. الدكتور هذا منعهم الشغل وانتهت حياته، ما اللي بيدفع له فلوس حوشه وما اللي بيدفع له اجار السياره والاقساط تاع السياره، رغم انه هو ما هوش معدي لحد، ورغم انه هو ضيع عمره او ضيع فتره من عمره باش هو يخش التخصص هذا، وهو جيت انفكتد من بيشنت تمام، وما قالولهاش ما تديرش عمليه للاتش اي في بوزيتيف، لكن بعدين قالوا له وقف شغل. So preventing the legal issue lead to an illegal one. نشوفوها بطريقه اخرى، يعني نحن لما نمنع الدكاتره، لما نقول لك انت دكتور ممنوع ان انت تدير عمليه لو انت اتش اي في بوزيتيف، فهكا اغلب الدكاتره ممكن يقولوا انا ليش مش هنادي حد يعني وانا عديت من مريض او بيشنت، فليش ليش نقول ان انا اتش اي في بوزيتيف؟ ممكن يقدروا الدكاتره يديروا في عمليات رغم انهم بوزيتيف وما يقولوهاش لحد، لكن لما انا اخليها حاجه ليجل ستاديز ان ما فيش انفكشن، الدكتور از نوت انفكتد، فلما اخليها ليجل افضل وندير لهم البروتوكول اللي قلنا عليه ضروري الفيرال لود يقعد لو، فهذه حاجه افضل. يعني ممكن لما تقعد الليجل حيديروا حاجات يعني حيديروها الليجل وحيعدوا الناس اكثر. وطبعا ما فيش ولا ستادي ولا اي بيشنت ولا اي كيس ريبورتد انفكتد من السيرجن نتاعها وهو ياخذ الدواء نتاعه. لو كان في 1 كيس ممكن مش حنصبه مع السيرجن اللي هو اتش اي في بوزيتيف، لكن عند توا ما فيش ولا كيس ريبورتد من اتش اي في بوزيتيف سيرجن ياخذ الدواء ويقيس لي الفيرال لود كل 3 شهور وطلع له ودار عمليه وعدا واحد ما فيش ولا كيس. تمام. الباقي ان شاء الله حيكمل زميلي محمد الغرياني.
تمام، شكرا يا محمد. تو نجول البارت الثاني من البرزنتيشن بتاعنا، بحيث ان احنا كنا كلامنا نظري. تمام، في ناس مرات ما تقتنعش بالكلام هذا، تو نجول في حقائق واثباتات ان الحاجه هذه حتكون شنو في صالح ان عادي ان عندنا allowed ان البيشنت اتش اي في بوزيتيف ان هو يجي شنو سيرجن. فاول كيس عندنا في 1983 the surgeon had required an HIV infection from an infected patient. تمام. يعني هنا الفكره ان هو الاتش اي في يعني شنو جايه من بيشنت. السيرجن هذا بعد ما عرف انه هو اتش اي في بوزيتيف دار عمليه على 3004 patients في من 1983 to 1993. تمام. فمن البيشنت هذول لقوا يعني اللي يقدروا يوصلوا لهم 983 داروا لهم شنو اتش اي في تيست. ونشوفوا نحن كم طلعت النتيجه بتاع التست هذينا، يعني حاله واحده فقط من مجموع الحالات هذينا كلها طلعت شنو بوزيتيف، يعني توريك ان الريسك بتاع الترانسميشن فروم سيرجن تو بيشنت يعني يكاد يكون شنو زيرو. عندنا الثانيه ان هي قال لك في another surgeon حتى هو اتش اي في بوزيتيف سيرجن اشتغل لمده 2 decades performed approximately 150 procedures per year، دار ممكن الى 1669 patients، دار لهم شنو عمليه بالسيرجن هذا، ولا patient كان listed وين في الدوله بتاعهم، كان listed على شنو؟ على HIV registry، معناها ان هم كلهم كاينين HIV نيجاتيف. فبعدين شنو؟ بعدين جو بيشوفوا البيشنت اللي هو يراقبوا فيهم، يقولوا يقدروا يوصلوا 545 patients هم اللي يقدروا يوصلوا لهم، وداروا لهم شنو؟ التست. البيشنت هذول ما يشكلوا الى 33% من ايش؟ من توتال بيشنتس. ونفس الفكره داروا لهم كلهم شنو؟ HIV تيست، ولا حاله فيهم كان شنو؟ بوزيتيف. يعني all the patients operated by the infected surgeon were negative. Guess what else? And both surgeons were not taking any HIV treatment. يعني كان الفيرال لود بتاعهم اصلا من الاساس كان شنو لو، ما بالك لو خذا البروفيلاكسيس تريتمنت حكى عليه خليفه كان الريسك حيكون زيرو، هو اصلا زيرو بس حينقص شنو؟ زياده. بعدين عندنا الستادي الاخرى اللي هو الاوكيبيشن ريسك اوف ترانسميشن، نفس الفكره من سيرجن تو بيشنت. ضاي هندرسون and his colleagues داروا estimation the risk of transmission of infection HIV infected surgeon related to percutaneous exposure اللي يقول هو 0.3 لكل شنو؟ لكل exposure. هذا بيش بالpercutaneous exposure. على داروا شافوا قاسوا اخرى الاكسبوجر الاخر اللي هو من الميوكس ممبرينز، يقول انه حيكون 0.09%، يعني almost زيرو. استادي واحده اخرى قارنوا شنو الاتش اي في بانذر انفكشوس فيروسز such as الهيباتيتس بي فيروس، لقوا اصلا ان الهيباتيتس بي فيروس الريسك نتاعها higher than الاتش اي في. يعني الهيباتيتس بي كان 6% to 30% compared to الاتش اي في كان 0.3%. يعني why should us plan the HIV infected person ان هو اصلا الريسك نتاعها كان 0.3%. السي دي سي دارت ستادي حتى هي من المعلومات هذينا كلهن و estimated the risk يعني نتاع getting an infection from an infected surgeon، يقولوا انه هو 2.4 to 24 episodes of transmission per 1 million. يعني لو تقدر تحسب هذه بالآلة الحاسبة حتطلع لك 0.00024%. يعني هذه من السي دي سي بروحها لقيت ان هي ما فيش يعني ريسك حتى هو almost زيرو. بالنسبه ما قال محمد البدري ان الفكره شنو؟ الفكره كلها في الفيزيشنز انه هو الفيرال لود نتاعه without treatment هل هو انفكتيف او لا. يعني الفكره كلها فيش في الفيرال لود اكثر من هي هل هو اتش اي في فيش سيرجن او لا. عندنا بعدين الفكره هذين الاستاديز شنو اللي جبناه اللي شفنا تو ريسك شنو؟ يعني almost 0%. الفكره تمت ان هي شنو؟ تمت كيف شنو؟ الاستجما ان هو الاتش اي في انفكتد سيرجن بدون اي فحوصات ان هو خلاص هذا this surgeon اتش اي في بوزيتيف سيرجن خلاص يعني ستوب ورك اند ما يديرش اي بروسيجر. لا هذه تمت شنو؟ هذه تمت ان هي شنو؟ استجما. فهم بشنو؟ بيحسنوها بحيث ان هو يعني لما واحد سيرجن يعرف ان هو مثلا اتش اي في، لازم قال محمد البدري ان هي تيجي حاجه يديروا الليجل، بالعكس خليه مثلا هو اتش اي في سيرجن ويدير الفحوصات نتاعه وياخذ التريتمنت ويخلي الفيرال لود نتاعه لو بحيث انه ينقص ريسك اوف ترانسميشن للبيشنت. على عكس انك انت مثلا لو تخليها ان هي استجما ان هو هذا لا اتش اي في سيرجن لا خلاص ستوب ورك. لكن لو مثلا تقعد هيك ما عادش يديروا فحوصات، يقعد هو لو مثلا طلع هو بوزيتيف مش حيقول مثلا المستشفى نتاعه، مش حيديروا ريبورتس، حيقعد شنو في مثلا لو في ريسك اصلا حيقعد الانتشار اكثر من للفيروس. بعدين عندنا في انجلند الشيف ميديكال اوفيسر فور انجلند هي البروفيسور دين سالي. شن قالت الفكره ان هو الهيلث كير وركر اللي هو infectious or not rather than شنو whether or not they were infected. part of a joke ان هي قالت اخرى ان في الوقت الحالي هذاك وقت التغير المناخي وكي ان الانسان يعني had more risk to be struck by lightning more than to be infected by an HIV infected surgeon. يعني نفس الفكره ان هو كل حاجه تثبت ان الريسك يعني almost زيرو. بعدها اخر حاجه نفس هذه حاجات بوادر ان هن تم يغيروا في الفكره نتاع الاتش اي في infected surgeons. البي ام اي خلاص اعلنت رسميا في 2014 ان هي خلاص لفتت البان اللي كان مفروض على الاتش اي في بوزيتيف دكتورز اللي هم شنو براكتسينج سيرجري، ما عادش في بان الانفكتد سيرجنز can freely work لكن هم يديروا في كل روتين انفستيجيشنز بتاعت الاتش اي في كل مره وان هم ياخذوا فيش في البروفيلاكسس تريتمنت تو ديكريس الفيرال لود اللي هم في البلد بتاعهم. ثانك يو فور listening. هذه الريفرنس بتاعتنا ان شاء الله يكون الراي بتاعكم معنا باذن الله. ثانك يو.
Now we are, I'm Hind Khair Rifai. Me and with my colleagues are against the idea of HIV surgeons, they can work. I'm gonna share the screen. Okay, I think this one. I'm gonna start now. Okay. First of all, I'm gonna talk about the good standard of surgical practice and care. First of all, ensuring the patient a good care and a safe environment for their special needs. So the doctor should be clean from any disease, and the environment of the hospital and the room of the doctor should be also safe. This is one of so important for the patient. The second thing that is, it's really more important also, that the hospital, you should be always presenting in the hospital, because I have some problem here. Okay, that's it. Okay, so the doctor or the surgeon should be always available on the hospital. So the HIV patient or surgeon will not always be attending on the hospital because he will get sick because of his low immunity. Also, the third and the most important one, that a surgeon should compromise safety for the patient and also the other health workers, the other colleagues and the other surgeons. Even a small flu, you should not go to the hospital if you have a small flu. So imagine if you have an HIV. The fourth thing, that people with HIV, in a long period, they will have something called HIV association dementia. So imagine how this will affect his work. Okay. Okay. Second thing I'm gonna talk about, that how surgeries affect the immune system. Can you imagine that the patient is under the surgery and under anesthesia and medication, his body will have low immunity, and the doctor or the surgeon who have HIV will do something by mistake. You know, we all know the complication of any surgery. By mistake, stick the needle on his, you know, his finger or something, and you know the risk of the patient. The risk is really high. Will be for the patient to get the HIV because his immunity is low, and the patient is also under the surgery, so he will get it so easily by blood. Before I talk about the HIV, we all know Dr. Khalifa gave us introduction about the HIV, so I'm not going to repeat it. We all know the HIV virus and disease, but we have to know that HIV destroys the important cells on the body that fight infections and other disease. So now we're gonna go for how HIV transmit. The most important thing, and that the thing that we are talking about is transmitted by the blood. And this is the important thing. We're talking about this. We're not talking about the semen and the private life. We're not talking the breast milk. We all know that the HIV is transmitted by those stuff, and vaginal fluid, rectal fluid, and all this. but we are more focusing on the blood and the sharing needles between workers, or even if you stuck your needle by accident, for sure, in your finger. Also, contact between broken skin or wounds, the mucous membrane, also you can get infected by HIV. I have here from the Centers for Disease Control and Prevention, they said that people who take the medications will have a low load of viral in their body, but they don't know exactly yet, is the viral load or the remission of the viral load in their bodies will let the other person get the infection or not. So they still don't know, the scientists, you know? So even if you take the medication and you have low viral load, we still don't know, is it that real that I can get the infection from the doctor? Also, we have to know something really important. If the doctor take the medication, the start of the medication will start within 6 months, not like before that. So imagine it's like half a year. Okay? Also here I bought this table with something really important and the risk of it from the Centers for Disease Control and Prevention. I'm not going to talk about the others. I'm going to talk about only the red one, because it's the important topic for us. It is about blood sharing syringe and other injection equipments. They said it's unknown but likely reduced risk. So why we're putting the patient on a harmful position or at risk to get the infection? Okay? In the end, I didn't do that. I'm gonna do it now. In the end, the Libyan law. The Libyan law, أو القانون الليبي، اللي هو لم يتم تحديثه إلى الآن. القانون رقم 418 المادة 16 بتنص على أنه عدم اللياقة الصحية لأي شخص يشتغل بمستشفى كدكتور، كصيدلي، تبعون التحاليل، أي شخص يشتغل بمستشفى لياقته الصحية أو عنده أي مرض لازم يقدم ورقة للجهات المسؤولة بالمستشفى، أوكي؟ وبعدين هن رح يفصلوه، ولو أثبت هذا الشيء إنه هو غير لائق لإنه يشتغل، وهو رح يكون at risk إنه يعني خطر لوظيفته and الenvironment تبعه، فرح تنتهي خدمته من وقت ما يطلع القرار أو يبين إنه he have the disease. Okay. But I want to talk about something that Dr. Saadi said, that there's no cases about doctors that get can affect other patient or something. It's because that we don't, the law is not with this thing. It's against it. So there's no doctors working on that. Also, in the end, I want to say that safe surgery will save lives. So us as a doctor, our health is really important, and will not get anything. We have to save our life from everything. At the same time, by doing this, we are saving also the patient, not ourselves or other people. And we're not like against it. We're like fully against it. Now I'm gonna go continue with my colleague. I have to just stop sharing this.
Assalamu alaikum, أنا اسمي سارة مفتاح الجازوي. The opponent team argued that with the proper precautions that usually the surgeons usually do, the risk of infection is low. And it's actually true, as CDC estimates the risk of patient infection by an HIV-positive surgeon may be as low as between 1 in 40,000 to 400,000 surgeries. However, physicians have an obligation under the long-established ethical principle of beneficence. This includes protecting patients from oneself once the surgeon becomes a victor of infection. First, do no harm. The American Medical Association contends that physicians who are HIV positive have an ethical obligation not to engage in any professional activity which has an identifiable risk of transmission of infection. And in this case, even 1 in 400,000 is considered identifiable. They also claim that by just informing everyone, it would be okay for the surgeon to continue the practice. Even though this fulfills one's obligation to inform the patient and the affiliated organizations, this once again does not satisfy the beneficence-based obligation. And at the end of the day, we do not live in an ideal world, so not every surgeon will disclose their HIV status, and this will put their patients in unwanted situation. Thank you so much. Now with my colleague Hadid.
Assalamu alaikum. My name is Hadid Lafi. So the opposing team has mentioned that there is medication to prevent an HIV transmission. Now, we all know that there is nothing that is 100% effective in treating or preventing HIV. But let's talk about pre- and post-exposure prophylaxis. So it's a type of short course of HIV medicines that we need to take very soon after a possible exposure to HIV. So the catch is that you have to start this medication within 72 hours after you were exposed to HIV, or it's not going to work, and every hour counts. One of our main problems with pre- and post-exposure prophylaxis is that you will need to take this medication every day for 4 weeks. And this will cost you around $2,000 US. So imagine that for every patient that this surgeon performs surgery on, we will need to give them this drug. Every patient, we need to give a budget of $2,000 US after being exposed to the surgery. So more about the pre- or post-exposure prophylaxis is that it's sold under the brand name Truvada, and it is a combination antiretroviral chemotherapy. As I said, it's meant to be taken for 4 weeks course. However, it's found that it's not 100% effective. It only reduces the risk when it's administered on a daily basis. So compliance is a very, very important factor. And even then, it's only 74% effective. So you're still putting your patient under a risk. Also, like any drug, Truvada has many side effects that range from nausea to liver toxicity, renal failure, and bone problems. And these are not side effects that your patient needs to have after surgery, and they probably even take post-surgery drugs, other drugs that are involved with the surgery that was performed on them. So you're just adding to the burden. Now, ladies and gentlemen, we are not trying to say that surgeons need to completely retire from their careers. We're not trying to stigmatize HIV surgeons. What we're saying is that they need to retire from clinical practice. They need to follow one of the primary principles that were taught to us as physicians is to first do no harm. So we're urging them to retire from their careers as surgeons, but redirect their talents and their knowledge into academics and into educating the newer generations of doctors. So this here satisfies all the associated ethical issues with HIV infected surgeons, and these are our references. Thank you very much for listening.
اوكي نشكر المجموعتين على التقديم بتاعهم. وضحوا الطريق المؤيد للفكره الفكره نتاعهم بطريقه كويسه، وعطينا فرصه للمجموعه المعارضه كذلك وضحوا الفكره نتاعهم. تو نعطوا فرصه للنقاش للفريق المؤيد انه هو يناقش، او اذا كان عنده معارضات على فكره الفريق المعارض، وكذلك عشان يوضح الحجه نتاعه بطريقه اكثر هنعطي الفرصه للفريق المؤيد، واي واحد فيهم يبي يقدم حيفتح المايك ويقدم. تفضل.
شكرا دراجي. اول حاجه انا بنحكي لكم على اللي قالها زميلتي هند، الدمنشيا. كيف ما قلت اي ديزيز يدير اني ديسابيليتي سيرجن والنتورك، يعني كيف اني اذر ديزيز ما فيش سيرجن حيجيب دمنشيا ونقول له اشتغل. هذه اولا. ثانيا القانون مش ارجمنت، يعني القانون دايرين لنا ناس كيفنا كيفهم. نحن كلامنا كان بيست اون ستادي مش بيست اون كلام ناس. نحن جبنا ستاديز ما فيش ريبورتد كيس، وستادي هذه مديوره ستادي، يعني فيه اتش اي في بوزيتيف سيرجن داروا عمليات، مش ما داروش فيه سيرجنز داروا عمليات والفيرال لود نتاعهم لو وما فيش كيس ريبورتد. فيعني القانون ماهوش حجه، كلامنا بيست اون ستادي مش جديد. ثالث حاجه تكلفه الدواء اللي قالت عليها زميلتي هديل. ليش انا نعطي فيه بروفلاكسس وانا في الستاديز نتاعي ما فيش اني ريبورتد كيس قال ان في واحد انفكت؟ انا نقدر ما اكلفش روحي قدامنا السيرجن ياخذ في دواء ولو فيرال ليفل ولو فيرال لود يقدر يدير سيرجن. وشكرا.
تمام. اعطينا فرصه للفريق المؤيد، اذا كان في اي حد من الفريق المؤيد يقدر انه خليفه جنيبر رافع يده. تفضل خليفه، اعطيك المايك.
تمام. انا عندي تعقيب على نقطه واحده في طريقه الارجيومنت نفسها. تمام. زميلتي هند هي حسيت شويه الموضوع كان بايس شويه. تمام. هي اوكي I can see ان هي she was trying to شنو make the idea look horrible. تمام. فإنها bringing up the symptoms and signs، وإن يعني حاجات اللي هنا شنو يعني يكون غالبا يعني شنو في end stage of that disease. تمام. بس without mentioning إن it's at the end of the disease مثلا، أو إن نحن نفس ما قلنا في البداية إن الإيدز نفسها it takes many years to develop. تمام. لدرجة إن البيشنت ما يحسش به إلا الانفلاماتوري فيز اللي في البداية اللي هي الفلو لايك symptoms اللي في البداية بس. تمام. بس later on يصير من الحاجات الأخرى اللي يصير يعني في الإيدز في نهاية يعني after many years، وهذا شنو هذا كله بدون treatment. فلو كان واخذ treatment يعني symptoms do not flare up، وبالتالي it doesn't look horrible as you may have shown it. أيوة. النقطة الثانية النقطة نتاع هند قالت لي إنه why bringing STDs and هذه. تمام. الرد بسيط جدا، يعني إن هي we're talking about transmission. موضوعنا في transmission مش موضوع إن نحن قاعدين نحكي هل هي blood أو إن هي STD. Plus we have brought many studies discussing the fact that إن حتى بالبلد وparentally by needles وكي إن الريسك ضئيلة جدا تكاد تكون صفر. آخر الدراسات اللي حكيت عليها في البداية ما فيش حد كان شنو infected. ثالث حاجة إن هديل حكت علي إن كيف حتعرف إن الشخص اللي قدامك هذا إن هل هو مستمر على التريتمنت أو مش مستمر، أو مستمر على البروفايلاكسس بروجرام مش مستمر. في حاجة اسمها رقابة طبية، ونقدر من خلالها إن إحنا شو نديروا إن يعني المكتب مسؤول في المستشفى الفلانية يقعد مسؤول عن إنه شنو إنه يقعد يقيس في الفيرال لود نتاعه ريجولارلي، بحيث إنه لو كان البيشنت نون كومبلاينت يحال إلى جهات أخرى وهم يدرون اللي يدرون يعني حتى يمكن يوقفوا من العمل. تمام. آخر حاجة لا خلاص تمام، هذينا 3 نقاط بس. شكرا.
تمام. تو عندنا هند رفاعي من الفريق المعارض رافعة يدها إن هي تبي تقدم.
تمام. شكرا دراجي. كمان شكرا لماي كوليجز سعيدة وخليفة. رح رد أول شيء عن خليفة حكالي إنه أنتي كنتي فايرنس شوي وهيك، بس نحن مش ضد مريض ال HIV patient، نحن مش ضده أبداً، بس we're saying just don't work as a doctor because you will put yourself and the patient at risk. Change your career as like do research. يعني أي دكتور في يفوت بأشياء تانية ما بيقدر يتعامل مع مرضى أو يتعامل مع عمليات. أوكي؟ فنحن مش ضد ال HIV patients لأنه it's a disease. يعني ما فينا نكون ضد هالشيء. نحن we're not against that. بس نحن we're against the idea that the surgeon will do a surgery for a patient, healthy patient, but he have a low immunity for sure during the surgery and stuff, and that's our point. Also, Khalifa said earlier about the case. He presents a case that two partners, and one of them was HIV patient, and his partner طلع مش HIV, بعدين طلع he cheated. We're not talking about the private life. We're talking about something serious on the work. You're gonna deal with a patient on the surgery, not our private life. And as I said, we're not against HIV patient. They can do whatever they want in their life, but don't put the patient in a harmful position. ساعتها said إنه القانون and نحن مش لازم نمشي عليه ونمشي على الكيسز والصف، بس نحن كل حياتنا عم تمشي على القوانين هاي. فكيف نحن لازم نوقف يعني عشان كم دكتور طلع عندهم إنه they didn't put the patient on harmful position أو they didn't affect other patients. نحن ما نمشي على القانون ونغير القانون. عرفتوا؟ بس آخر شيء in the end بدي أحكي إنه اسأل حالك هالسؤال. لو أنت شخص من عائلتك، أوكي؟ عرفت إنه الدكتور يلي رح يعمل له عملية هو HIV positive، رح تقول عادي؟ أو أنت شخص على حالك رح تكمل هالشيء أو لا؟ رح تحط عائلتك أو حالك in a risk position يعني. I don't think so. Thank you.
شكرا. هند، نعطي الفرصة إذا كان أحد من الفريق المعارض يفتح المايك ويقدر يحكي.
السلام عليكم. نبي نرد بس على النقطة اللي هم حكوها على إنه جابوا studies وقالوا في الstudies هذينا إن هم surgeons they were HIV infected وإن هم they performed around 3,000 surgeries, 1,500 surgeries, and all of their patients were HIV negative. So the main problem in these studies is that not every patient was calculated. So, for example, in one study there were 3,000 patients, and only 1,000 of them were tested. What about the other 2,000? Do they have HIV? Did they die from HIV? We don't know that. So even though there is a risk of 0.3% to transmit an HIV infection to another patient, from a surgeon to a patient, that is still a considerable risk. And that's still putting your patient under an unnecessary harm. And like I mentioned, and I'm going to mention it again because it's very, very important, one of the primary principles we are taught as physicians is first, do no harm. So no matter, even if the risk is 0.3, it is still a considerable risk. You're still putting them under harm. And at the end of the day, we mainly care about not putting our patients under any other unnecessary risks. Thank you.
نشكر الفريق المعارض على تقديم الرأي تاعه. نقدم فرصة للفريق المؤيد إذا كان عندهم أي تقديم. تمام. مش حد فيهم داير يزمان. تمام. حنقدر نكتفي عن أنا بالنسبة للديبيت للمناظرات في اليوم العلمي. المناظرات هي تعتبر كما قلنا ان هي احد الانشطه اللي تقدم فيها كليه الطب البشري، وهذه الطريقه حيستمر بها الديبيت لان يقتنع الجمهور باحدى الافكار اللي يقدموها الفريقين. زي ما نعرفوا الديبيت نيفر اندز، فحيكون الرد بالفريقين يردوا على بعضهم اكثر ويكون في افكار اكثر. نشكر الفريقين على الرأي اللي قدموه على تقديمهم، والسلام عليكم ورحمة الله وبركاته.
وصلنا توا للفقرة التالية وهي فقرة البوسترز أو الملصقات العلمية اللي حيقدمها طالبة من السنة الرابعة والسنة الخامسة المؤسسة وبعض من طلبة الامتياز. خلونا نشوفهم لبعضنا ونرجع.
Hello, my name is Dimi Tohi. I'm a fourth-year medical student from the Libyan International Medical University, and my poster today is about stem cell therapy. Now, you've probably heard about stem cells in the news, and you've probably wondered if it could help a loved one with an illness, and you've probably wondered what stem cells are in general. So what are the stem cells? They are the body's raw material, and they can differentiate into any type of cell in the body: fat cells, red blood cells, neurons, and so on. Now, when was it discovered? In the mid-1800s, it was discovered that cells were basically the building blocks of life. And throughout history, they've been making major breakthroughs in this field. For example, in 1978, stem cells were discovered in the human cord blood. Also, it was discovered that in 1997, not discovered, but they found out that they could clone a lamb from stem cells, and that was pretty incredible. As for the how, stem cell therapy is also known as regenerative medicine. Now, we have 6 stages of stem cell therapy. First of all, you remove these stem cells from the bone marrow into the blood using chemotherapy. Then you get a machine, and you collect the blood that contains the stem cells, and you separate it, and you put the stem cells in a tube and freeze it. While that's happening, you continue the chemotherapy to eradicate the immune system. I'll get to that later why we do that. Then we bring back the stem cells, we infuse it as a drip into the patient's body, and within a few months to years, the patient will recover. Now, I said from before that we apply more chemotherapy to eradicate the immune system due to challenges. For example, immunological rejection to the stem cells. Your immune system might think of it as a foreign body and attacks it. Another thing is that stem cells are precancerous. It could have cancerous potential and cause cancer basically in the body. As for the where, due to cultural and religious views, only a few countries actually allow this type of thing to happen or research to happen. For example, the countries in green, for example, Australia, China, UK, these have stem cells research facilities, and they actually allow it and allow people to actually take treatment from that. The countries in yellow and red have a few more restrictions in stem cell therapy due to religious views, like Christianity and Catholics. They usually think of it as an act of God. The stem cell therapy, you're creating the cells of the body and so on. So it has a few restrictions in it. And as for the countries in white, for example, Africa and parts of South America, and our country Libya, they don't have any type of stem cell facilities or research or funding or anything about that. As for Libya, I don't know if it's due to religious views or for funding, but we don't have it, basically. In conclusion, I think stem cell therapy is a way to treat many diseases throughout the world, but as I said, due to religious and cultural views, there are many restrictions on this topic, and many people are against it. But maybe in the following years, things will change, because I really believe that this is the future stem cell therapy. Thank you for listening. Goodbye.
Hello, this is Mohammed Khalid Dawes, a fourth-year medical student at the Libyan International Medical University. This will be my contribution to the scientific day organized by my faculty. Now, the topic today, or the question that I have put forward today, is: can nano-based immune technology be used to reduce organ transplant rejection? Now, what is nano-immune technology? Briefly, it is a new methodology applied in the study of immunology specifically, a nanotechnology-based system or systems that can be modified to target specific cells of the immune system and deliver chemotherapeutic agents or immunomodulating agents, priming and activating innate and antigen-specific memory immune responses. Now, in terms of its applications, we have applications that are in medicine in general and those in respect to organ transplant. In medicine, we have the localized, sustained, and controlled delivery of drugs and bioactive factors, also the imaging of clinically relevant biomarkers and functional parameters for diagnosis and treatment. Now, applications in organ transplantation are threefold. Firstly, delivery of immune suppressants and other drugs, also donor-specific tolerance and rejection, and finally, imaging, diagnostic, and other uses. Now, challenges of transplantation, we all know that they are quite immense and very, very common. Now, although improved surgical procedures and the use of powerful immune suppressive drugs, cell and organ transplantations have become the standard care for millions of patients with end-stage organ failure. However, obstacles such as organ shortages, graft failure, lifelong administration of immune suppressants, and their systemic use, they lead to poor patient compliance and causing eventual morbidity and mortality. And those are problems that we have to put in perspective for us to find a better or a clearer type of approach to find a more successful outcome. And you see in figure A, or figure 1, sorry, we have a little graph that was put forward by the Kidney Transplant Association in America in 2014, demonstrating the vast difference in patients who are undergoing transplantations and the patients who are on the waiting list. And as you see, it's just another representation of the many obstacles faced by patients requiring transplantation. Now, methodology. We have the localized, sustained, and controlled delivery of drugs and bioactive agents. Liposomes, nanochannels, membranes, and other nanocarriers. To get further into that, we have the lipid-based formulations such as emulsions, liposomes, polymeric missiles, have demonstrated reliable alternatives to transport the water-insoluble type therapeutics. Also, the role of nanoparticles in the distribution of disruption of signaling pathways in T-cell activation and donor antibody functions. And finally, the central innovation of the sustained delivery technology is the use of microfabricated nanochannel membranes, which, like in hourglass, passively control the release of molecules. Secondly, we have the implantable devices and biocapsules. They are nanotechnology-based tunable implant devices that have the potential to adjust drug release based on the circadian rhythm of inflammatory markers. This type of synchronization of drug delivery to biocycles using these devices represents an additional step towards individualized medicine. Now, as we see here in figure 2 or picture A, these are remote-controlled, battery-powered drug reservoir type devices, which are used by the doctors in research. Now, also we have figure 3 or picture B, and that's just another graph demonstrating the therapeutic level, and these waves represent its simultaneous action with the biocycles of the patient. Now, thirdly, we have nanoglands, nanoparticles in transplant. These nanotechnology-based encapsulation systems have successfully supported engraftment of pancreatic islets. These encapsulation systems protect the transplanted cells from immune attacks and also provide a physiological environment promoting cell survival and vascularization. Finally, we are looking at the imaging and functional parameters for diagnosis. Nanotechnology has made substantial progress in the world of medical imaging. Similar to the ability to deliver therapeutics, we can also deliver contrast agents to assist in delineating anatomy and physiology of for medical imaging. Now, with respect to the transplant field, nanoparticle approach for imaging have predominantly been used to monitor transplanted grafts, track distribution, of administered stem cells, gauge viability, of implanted cells within scaffold or within tissues, and finally to evaluate drug release from these scaffolds. Now, these are devices that have been implanted and used in research. What is the material that they're made out of? It is porous silicon. Now, porous silicon has been widely investigated for its biodegradability, biocompatibility, also features such as high surface area and tunable shapes and sizes. Recently, the multi-stage nanovectors, such as disc-shaped porous silicon, were developed to strategically overcome the body's biological barriers through unique size and shape tailoring. Now, to conclude, nanotechnology does exhibit a new way to attack the variable obstacles that organ and cell transplantations present. The induction of nanotechnology has shown success, including the recent use of nanocomposite polymers as scaffoldings for the synthesis of a successfully implanted artificial trachea. New development in nanomaterials, such as the inclusion of bioactive properties able to enhance cell growth and function, offer a promising future for today's transplant therapies and can improve the prognosis of transplant patients. These are the references, and thank you for your attention.
Welcome everyone in our online scientific day in Libya International Medical University. Today I'm going to present you my poster which talk about how far we could get intervention without open surgery in cardiology with me, Malak Lagori. So of course one of your family member, friend or even neighbor had a cardiac problem, but he or she not candidated to invasive open surgery, either have ischemic, valvular or even congenital heart disease. Thus, they need less invasive intervention with those devices that I'm going to talk about it today. Those devices help to avoid the open surgery, decrease the morbidity, mortality, and not to forget decrease the hospital stay. Also, something I have to mention that the devices still some of them not used here in Libya, as in other country, but we have the old version of them. Some of those still just recently take the FDA approved. So going through back in the cardiology history, Werner Forsman in the 1929 did the first heart catheterization on himself, and the two who introduced the diagnostic cardiac catheterization were Andrew Carned and Dickinson Richard in the early 40s. Not to forget, Maison Sons in the early 60s described the selective coronary angiograph, but the biggest jump was the catheter-based intervention in the late 70s by Andrew Kirschneising. So back to main subject of the poster today, I'm going to talk about 5 diseases and their devices, which are atrial septal defect, patent ductus arteriosus, aortic stenosis, mitral stenosis, and the last one would be the mitral regurgitation. So let's start with the first one, atrial septal defect, which account for 7% of all congenital heart disease. Had an opening varying in size and place in the atrial septa, have 4 types: secundum, premium, sinus venosus, and the coronary sinus. The most common one is the secundum, which is occur in the middle of the wall between the atria. The closure of the ASD depend on the hemodynamic and morphological feature, or you could say difficulties. The hemodynamic difficulty are severe pulmonary hypertension, ventricular dysfunction, and restrictive left ventricular complaint after ASD closure. The morphological difficulty are the large size, more than 30 mm, wide rim deficiency, and the multiple defect. But after the embolizer occluder, embolizer septal occluder, this one, we could treat the ASD without open surgery, but not for large size defect or multiple. The embolizer crepiform and the core helix device, those two could down for a large size defect by placing more than device side by side. Also could be used for multiple defect, which the first couldn't do it. If you see here the angiography and how it look even if you're not cardiologist, you could see the defect area here, this dark area, which is the opening area, and the device when they start to open, and when they completely open the device, this shadow, dark area, completely disappears. So it is very, very useful, those devices in the AST. Okay, so moving to the next one, which is the patent ductus arteriosus, with diagnosis in the childhood, but could delay the treatment to the adulthood, which will reflect a lot of complication. Before, that was the problem, the fear of surgery, but now it's not issue. Those three devices affect the same, but the embolizer duct occluder have the high success rate, over 95%, to treat the defect at 6 months. The NetOcclude, the new device NetOcclude, different in the route of entry, which is enter from the arterial side through the BDA through the aorta. This is the only difference here. The next thing, which is the aortic stenosis. Aortic stenosis, which is a degenerative progression, had a high mortality. Thus, who not qualify for surgery must do TAVR, transcatheter aortic replacement, with 4 devices that I'm going to talk about it. Those 4. First one, which is Edward Spain 3, improved the design of catheter and sheath, have result in delivery profile of 14 French for 23 to 26 millimeter valve and 60 French for 29 millimeter valve. Also, it need vessel size between 5.5 to 6 millimeter. The next one, which is the Medtronic core valve, which is one of the indication for severe aortic stenosis with high risk for surgery, gained the core valve in 2009 and took the FDA approved in 2014. The third one, which is the Portico valve, is shorter than the core valve, reduce the risk for the conduction injury. So if we afraid of conduction problem or the vessels very fragile, so this is it's a good option. The last one, which is the direct flow valve, non-metallic, made of bovine pericardium and expanded cuff. It's indicated for severe aortic stenosis, and it's used in the USA, but didn't take the FDA approved in USA for patients who are aortic regurgitation or performed bicuspid before. So it's only approved for aortic stenosis. The last thing, the mitral valve. Talk about the mitral stenosis and the mitral regurgitation. The mitral stenosis, which is decrease in the diameter of the valve here need inu balloon, which is available range from 24 to 30 millimeter in diameter. But the amazing thing in this improvement that in the mitral stenosis was only surgical option, but after 80s it completely changed to be the first option, which is the inu balloon. I'll show you here picture. This one here, the balloon outside, and here with echo you could see this balloon. Okay, the next thing, which is the mitral regurgitation, which is more common than the mitral stenosis. We have two new devices, the mitral clip development and the Caroline contour system. The first one, which is the mitral clip development system, this device enters into the mitral valve, then open the clip, then pull it up, and thus we reduce the regurgitation. The second one, which is the newest, which is the Carolina mitral contour system, which is implant in the coronary sinus, thus made a ring around the mitral valve. This device, as you see, have a proximal and distal anchor connected with nitinol shaping rod pin. In 2019, in France, in a cardiology conference, they show a case. A 81 female had a severe mitral regurgitation with dyspnea. After doing a Caroline device, the patient decreased the medication of heart failure, and the patient died after 2 years from cancer. So she died from another cause that she had. Like she had a severe mitral regurgitation, and then she died from a cancer. So it's really painful. So that's it. Those are my references. Thank you for your watching. Hope to be painful for you. And if you have anything you want to ask me, you can email me malak.algori@gmail.com. Thank you for your watching.
السلام عليكم، أنا الطالب خليل حماد خليل، طالب سنة رابعة. اليوم حنقدم البوستر على refractive eye surgery. تمام. refractive eye surgery, a brief introduction about it. هي عبارة عن eye surgery used to improve the refractive state of the eye and decrease or eliminate any dependency on glasses or contact lenses. This can include various methods of surgical remodeling of the cornea, or as you can call it, cataract surgery. The most common methods that are used today uses an excimer laser to reshape the curvature of the cornea. The main aim of refractive eye surgery, as its name, is to treat or fix refractive errors. طبعا there's different types of refractive errors. There's astigmatism. طبعا احنا the normal eyesight يخش a couple lenses, a couple rays يخشن into the eyes, and they all join in one point at the back of the eye, which is the focal point in the retina. عندك في الاستجماتيزم the focal point ممكن تكون في مكانها ممكن ما تكونش في مكانها، بس الفكرة في الفوكال point بتاع الاستجماتيزم the rays don't all just focus on one point. There's many multiple different focal points. عندنا myopia و hyperopia. عندنا الهايبروبيا تلقى الفوكال بوينت جاية وراء الريتنا، فجي السايت ما جيتش تمام. وعندك مايوبيا تجد اللي هي نير سايتنس، يجد الفوكال بوينت جاية قبل الريتنا، يعني هي المسافة مش موصلة عند النهاية. طبعا التريتمنت تاع وحدة تاع الفار سايتنس هي الكونفكس لينز والأخرى كونكيف. طبعا احنا حندو على two different types of refractive eye surgery، هنا LASIK or PRK. هنا in reality they aren't that much different, but there's a slight difference in the procedure متاع الليزك. الليزك هي عبارة عن نفس الidea as you can see here. الليزك eye surgery عبارة عن تعطي anesthetic drop، والmain difference هو creating a flap. الليزك you create a flap، الأخرى you don't create a flap, you just directly fix it. طبعا after you create a flap في الليزك تضرب الليزر laser to reshape the eye، بعدها close the flap، بعدها ال eye heals by itself. طبعا في survey دارينا by the تقريبا اسمها الموقع worldeye.com. 3% of the patients that did this operation said they had no regrets. Only 12% had to do another surgery to fix their eye in the desired span of time. 45% never had any side effects, even minor ones. 53% reported initial, and 59% said they had no regrets. And 60% of people said the operation was perfect and fulfilled all their expectations. تمام. طبعا which surgery is better for you؟ طبعا زي ما قلنا ال PRK هي it's most often recommended as an alternative for people who are not good candidates for LASIK. عادة البيشنت كان عندهم thin corneas, so it's harder for them to create a flap by the surgeons, or steep corneas, or history of dry eye syndrome, large pupils, or people who are concerned by the surgery creating a flap. And the complications are not very common, but they still happen, some of them are very minor, some of them are very dangerous. For example, dry eyes isn't that dangerous. It can be treated by artificial tears, something like that. عندك layers of halos, which are during nighttime while you're driving the headlights, you can see them as زي المغبشات حاجة هيك. ممكن تكون incomplete or button, ممكن تكون folds or slip flap. كان diffuse laminar keratitis اللي هي non-infectious inflammation، أو ممكن تصير infection، أو post LASIK ectasia. هذه تقريبا هي one of the most dangerous ones. It's very rare, but when it happens, it's very bad. تمام. Comparison, this is like comparison. طبعا ال PRK زي ما قلت من قبل هو it's just a bit safer in the fact that you don't have to create a flap. That's really just it. الهيلينج بتاع LASIK starts straight after the operation. ممكن the patient can see a difference in the first day of the operation. Unlike the PRK, it might take from 2 to 8 weeks for the patient to start noticing any differences. Refractive error correction, طبعا هنا I read different sources. في اللي يقولوا إن they're exactly the same، في اللي يقول لا LASIK is a bit superior, but in general they're very similar, even in refractive error correction. To conclude this poster, طبعا here refractive surgery is an excellent procedure for most patients who don't like wearing glasses. Hence, as my title of my poster says, do you look bad in glasses? Or people who don't like wearing contact lenses, although some complications may be associated with these procedures, in my opinion and in many others, the advantages heavily outweigh the disadvantages, and hence why they can be overlooked. These are my references. Thank you for listening. Wassalamu alaikum.
Assalamu alaikum. I will start today by introducing ourselves. I'm Dr. Tala Al-Ojli, along with my colleagues Dr. Raghda Sharif and Dr. Lina Shaib. We will present our findings about how Alzheimer's affects women more than men. I will leave you now with Dr. Lina, who will start off with our discussion.
Our study topic is about Alzheimer's and its relation to women. About 25 million caregivers worldwide have Alzheimer's disease. 2/3 of them are women. 60% of those women are over the age of 60. We can say in the menopausal state. As presented in the figure, there is a slight increase in the incidence in women over the age of 70 to 80. 60% of those women are over the age of 60. Did you know that women above 60 are twice as likely to develop Alzheimer's disease than develop breast cancer? So moving on to the risk factors. Previously, the higher proportion of women affected by Alzheimer's disease was attributed to their longer life expectancy relative to men. But several emerging lines of evidence point to sex and gender-specific Alzheimer's disease risk factors, such as, I'm going to start talking about the genetic risks, family history, and the apolipoprotein E gene that provides instructions for making a protein called the apolipoprotein E. This protein combines with fat lipids in the body to perform molecules called lipoproteins. As we know, the lipoproteins are responsible for packaging cholesterol and other fats and carrying them through the bloodstream. The second point is medical conditions, as depression. As we know, depression is a serious problem. Many researchers believe that depression is a risk factor of dementia, whereas others believe it may be an early symptoms of the disease itself, or both. We have stroke and diabetes mellitus too. Hormonal-related risks as menopause and thyroid disease will be discussed with my colleague Dr. Tala in the next topic. Lifestyle factors as smoking, diet. Poor diet and unhealthy diet, high in saturated fat, sugar and salt, can increase the risk of many other illnesses besides Alzheimer's disease, like type 2 diabetes, cardiovascular diseases, and also dementia. Moving on to Dr. Tala, who will discuss the new theories of Alzheimer's disease in women. Throughout the previous years, several researches have been conducted to establish why Alzheimer's occurs in women more than men. Today, we will talk about some of many theories discovered during the studies, researches, and clinical trials. Menopause state was found to be the main factor contributing to higher beta amyloid levels, lower glucose metabolism, and lower gray matter volume and white matter volume in women. This suggests that hormonal factors may predict who will have brain changes. Although all sex hormones are likely involved, low estrogen levels were linked to Alzheimer's biomarker abnormalities. After menopausal state, hormone therapy and hysterectomy were the factors strongly linked to brain biomarkers difference in genders, along with other factors such as thyroid disease, which is a hormone-linked risk factor. The second most talked about theory is the mitochondrial toxicity of amyloid beta peptides in regards to gender difference. Researchers show that the mitochondria in young females are protected against amyloid beta toxicity, generating less reactive oxygen and releasing less apoptotic signals than those found in men. Older females are likely to lose this advantage of estrogenic compounds. Estrogenic actions may be important in protecting cells from toxicity, and therefore this suggests a possible treatment or prevention strategy. Another theory is about the Alzheimer's-related protein in the brain, called the tau, which spreads through the brain, turning other proteins into tangles, leading to brain cell death. It is found that the tau network differs in women than in men. As in women, there are more bridging regions, increasing the speed of accumulation and therefore leading to a greater risk of Alzheimer's disease. My colleague, Dr. Raghda, will now discuss other mechanisms of neuropathology in Alzheimer's.
Although the neuropathology of Alzheimer's disease isn't completely understood until now, as mentioned by my colleague Dr. Tala, there is research suggests that there is many of theory of action. I will talk about some of them now. Here we've got the cell membrane of the neuron in the brain. And this membrane, you've got this molecule is called amyloid precursor protein, or APP, one of the end on the cell and the other end of, outside the cell. This molecule helps the neuron to grow and repair. Because it's a protein, same the other protein gets used and break down and recycle. Normal, it's shut up by enzyme alpha secretase from its body, and gamma secretase. This shut up are soluble and goes away. If another enzyme beta secretase teams up with alpha secretase, then we have problem because there is leftover fragment is insoluble. Then increase monomers called amyloid beta. These monomers become sticky and bind together and form plaque. This plaque becomes between the neuron and other and disrupt signal between the neuron. And then the brain function is impaired. As we see in this picture, after the concentration of the amyloid beta is high, then this leads to a white in the ventricle and decrease the gray and white matter. At the end, in conclusion, we can now conclude that there are significant hormonal biomarkers that influence Alzheimer's disease. The next important step is to conduct further researches and clinically trials to establish a safe approach in which hormonal replacement therapy may prevent or treat Alzheimer's disease without the possible potential side effects of hormonal replacement therapy, such as breast cancer and heart disease.
These are our references, and thank you for listening.
Assalamu alaikum. This poster giving an idea about the spinal muscular atrophy disease and 3 strategies for treatment. First, the spinal muscular atrophy is an autosomal recessive disorder characterized by progressive weakness of the lower motor neurons. In 1995, the spinal muscular atrophy disease-causing gene termed the survival motor neuron, or SMN, was discovered. This gene produces survival motor neuron protein, and actually each individual has two SMN genes, SMN1 gene and SMN2 gene. The first gene produces the full-length survival motor neuron protein, and in contrast, the expression of the second gene produces short protein. And more than 95% of patients with spinal muscular atrophy have mutation in the SMN1 gene on chromosome 5. And all patients with spinal muscular atrophy retain at least one copy of SMN2 gene, which generates only 10% of the amount of full-length survival motor neuron protein versus the other gene. And this genomic organization provides a therapeutic pathway to promote the survival motor neuron 2 gene existing in all patients to function like the missing SMN1 gene. So the studies are including raising SMN levels through gene therapy and a prenatal transplantation of a human amniotic fluid stem cells, and raising SMN levels using antisense oligonucleotides. The first study published on December 2018 in molecular therapy, researchers were able to fix a mutation in the SMN1 gene in mice modeling the disease. While they were still inside their mother's uterus, they found that the treated mice lived longer and had fewer symptoms than untreated animals. And in a result, a non-replicating adeno-associated virus capsid is used to deliver a copy of a human survival motor neuron gene through a drug called Zolgensma on May 2019. The second study is about stem cell transplantation or prenatal transplantation of a human amniotic fluid stem cells through engrafting enriched neural cells. This will help reduce neurotrophic factors that are responsible for the growth of mature neuron cells. And a result, prenatal stem cell therapy preserves the time window to treat disease in utero with much less cell number. The last study is about making sense of antisense, which means they designed oligonucleotides that will change the splicing of survival motor neuron 2 gene to make more functional survival motor neuron protein, which are produced by the SMN1 gene. And in result, the US Food and Drug Administration on December 2016 approved the antisense therapy through a drug called Spinraza for the treatment of spinal muscular atrophy. So that's all. And in conclusion, researchers have focused on strategies to increase the body's production of survival motor neuron protein lacking in chromosome 5, and the approaches include methods to help motor neurons survive and to maximize the child's independence and increase the quality of life. If you would like to know more about this disease and these strategies and treatment, these are the references, and thank you.
Hello everyone, my name is Rani Mohammad Muftah. I'm a fourth year medical student in Libyan International Medical University. My poster will be talking about how tilapia fish scales can aid in healing process of skin burns. First of all, we should know that the skin burn is a type of injury caused by heat, electricity, or friction, and other causes. And there is the 3 degrees of skin burns. We got the 1st degree, 2nd degree, and the 3rd degree. The 1st degree, which is affecting the epidermis layer, the 2nd degree, which is affecting the epidermis and dermis layer, while the 3rd degree, which is affecting the epidermis, dermis, and may go to the subcutaneous layer. As for tilapia fish, or as it's known for its scientific name, Orchimorus niloticus, it's a type of large genus of tilapia fish, and it exists in large amounts in African coasts, Australian coasts, and Brazilian coasts. The skin of this fish is very beneficial in treating skin burns because they're rich in type 1 and 3 collagen fibers, which they help in formation of a scar. Scientists of Federal University in Ceará in northern Brazil found that tilapia skin has a moisture and collagen that can help in healing. In Jaguaribe, Brazil in 2017, it has been used over 56 patients to treat second and third degree burns. They apply the skin directly into the burned area and covered with bandage. Then after 10 days, doctor removed the bandage and the fish's skin is dried out and loosened from the burned skin, so it can peel it away. There is another study made in China but in rodents to study the effect of marine collagen peptides that are present in fish's skin in 28 days. That is being used equally on female and male rabbits by dividing them into 3 groups. There is the model group, the positive group, and MCB group. The model group, which is they don't use anything, the positive group, which they use the moist is called ointment, and the MCB group, which they're using the MCB. In histological examination, after 7 days, the coagulation and necrosis of the whole epidermis layer is present and there is no significant differences. After 14 days, there is a few wounds covered by new epidermis and little proliferation of mature granulation tissue found in the first and the second groups. But in MCP group, it had over half wounds covered by new epidermis and much granulation tissue proliferation of the dermis. After 21 days, the MCP and the positive groups almost covered by new epidermis, hair follicles, fibroblasts, and capillaries. That is compared to the model group. Lastly, after 28 days, wounds are completely covered among the 3 groups. So, as in conclusion, the MCBs from the tilapia skin can accelerate in healing process and can improve in healing effects by reducing inflammation, promoting granulation tissue formation, and other beneficial effects. Besides, the fish's skin is less expensive and it's also available, and instead of throwing it away, it can be recycled as a beneficial treatment of skin burns. Compared to the gauzes, which is sometimes you replace it twice a day, tilapia can be kept for a week, then replace it after it's dried out. Thank you.
Hello, I'm Judy Futaina, a 5th year medical student. Today I will present my poster for the scientific day entitled "With What a Female Surgeon World Is." My poster is a study about the obstacles that make a surgery far from the female doctor's ambitions in Libyan hospitals and universities. As introduction, I will start with a quick summary about the history of women in surgery. In the Western world, the history of women in surgery dates back to 3500 before Christ in Egypt, Italy, and Greece. Women had to impersonate men in order to practice surgery, with the most famous being Dr. James Barry, who concealed her sex throughout the duration of her practice and was only found to be a female after her death in 1865. This was during the Middle Ages, which are considered a very difficult and disappointing time for women in medicine. A century later, until 1970, only up to 6% of the medical school admissions were women, and the American College of Surgeons admitted its first woman in 1913. In 2001, the number of physicians who were female rose to 24%. The fact there are now as many female medical students compared with male students in universities, males still outnumber women in number of procedure specialties, as we can see on this diagram of percentage of female doctors in different specialties in UK hospitals at 2012. The higher percentage for the pediatric and plastic surgeons, but it's still below the 25%. This situation would appear to be similar with most developed and developing countries. In previous studies, such as a published paper entitled Postgraduate Medical Journal in 2012 in UK hospital, it was shown that the work-life balance, it's the main deterrent in a surgical career, and the paucity of the female role models are perceived sexual discrimination may cause female doctors to dismiss surgery as a career. Up to our knowledge, my study is the first of its kind in Libya. It's a cross-sectional studies in 2 different groups of participants. First group was a female medical student in 4th and 5th and internship year, in Libyan private and public universities. The second group was female residents in Libyan hospital. A survey was published via Facebook medical groups and Twitter in June 2020. The questionnaire was designed to seek subjective answers related to a career choice, work-life balance, and sexual discrimination. These diagrams are a summary of the results. We've had a total of 160 participants with 124 medical students and 36 resident doctors. We found that 33% of participants have considered surgery as a specialty. 49% weren't sure about it. This may relate to a higher expectations of medical students at this time. Generally, houseworking and raising children are the responsibilities of the mother. Therefore, being a surgeon or considering becoming one renders these responsibilities more hard or difficult. The need for balance between a career and responsibilities are essential to maintain an adaptable lifestyle. It was noticed that 65% of participants found this issue a major obstacle. Surgeons usually have many tasks including ward round, operation, clinical patients, and administrations of them, which in turn require long working hours. 74% of the participants agreed that longer working hours are a huge dump. The Eastern society as a whole still give dominance and based confidence to men's abilities in the surgical field. This renders 65% of female medical students to choose the sexual discrimination as a reason that could prevent them from choosing a surgical career. The dominance displayed by a male in the surgical domain is implied by both the physiology of their bodies, mentality of the society, as well as make responsibilities are concentrated on work itself. The nature of the male society and what gives the male doctor of infinite power have made a female student anxious about being harassed and disturbed, so that 68% of the students and doctors found harassment during work, while male is a major problem. Surgery is one of the professions Surgery is one of the professions that need the courage due to its blood splatter and freezing graphics, and it requires rapid life-saving decisions. Only 23% of participants noted it as an obstacle medical career. In general, surgical career concentrates greatly on the privacy of the patient during the examination. The examination of the perianal area, male genitalia, rectal examination, as example, may cause an embarrassment to a female doctor when examining it. Finally, 73% of participants believe that the presence of the consult surgeons and male heads of surgical departments are not giving enough support and opportunities to new doctors, especially female, and 14 were not sure if they had a career or not. To conclude, the balance between work and social life and nature circumstances of the work, including working hours and sexual discrimination in society, are the most important obstacles for female doctors who wish to specialize in surgery. To be a successful female surgeon doesn't always mean being famous or needing to be at the top of the class. Being one of the women who changed the percentage of the female surgeons make you an inspiration. If you need to check for more information, these are my references. Thank you.
Hello and welcome. My name is Zurida Muhammad Bajaja, a fourth year medical student at Libya International Medical University. Before we start, I just want you to think about your body position for a second as you're watching this. Just think about how you're sitting. Maybe you're sort of leaning over a table or slumped back on a chair. If you're looking at this on a mobile device, for example, your arms up and by your side, you're a little hunched over your neck, and you may wonder, what's this doing to your body? Well, like it or not, this is probably causing some pain, maybe in your shoulders or between your shoulder plates. And some doctors even gave this a name. It's called text neck syndrome, or TNS for short. Now you're probably wondering, what's TNS? Well, it's basically a syndrome involving the head, neck, and shoulders, resulting from repetitive stress injury on the spine. When the head is sort of in a neutral position, as you can see in this figure, when your ears are lined up with your shoulder, the average human head weighs about 10 to 12 pounds, more for some people and less for others. But think about it. As you start moving your head a few degrees forward, few inches forward, you start to put more force, more weight at the back of the neck. For example, when you are at 15 degrees, your head weighs about 27 pounds. At 30 degrees, 40 pounds, and so on. Well, that's probably what's causing some of the problems over time. That can lead to flattening out the natural curve of the neck, as you can see in this X-ray over here, which can lead to discompression, herniation, nerve or muscle damage, and allow that pain. Here in the middle, we have two studies. The first one aimed to check awareness and knowledge of TNS, which was conducted on young adult population using a self-administrated questionnaire that included asking them about phone usage, their hazards of excess phone usage, and if they ever heard about TNS. And if their answer was yes, what did they know about it? The results were, as you can see over here, 65% of people never heard of TNS, 27% of people did, but they didn't really know anything about it. Only 8% of people had some knowledge about TNS. The other study was aimed at checking the relationship between prolonged use of handheld devices and neck pain. Like, how many minutes or hours of looking down on your phone does it take for your neck to start aching? So the study was conducted on 2,353 students by a questionnaire regarding that matter, also using a neck disability index to evaluate the degree of the pain. The results revealed that 66.9% of people would feel neck pain after more than 2 hours, and that 48% of people would feel neck pain after only a few minutes. So, who knows, maybe you feel neck pain right now while watching this. So if you do, I would advise you to change your posture. Anyhow, as for the neck disability index, the results were that 62.2% of people had a score of 0 to 4, suggesting no disability. 32.8% of people had a score of 5 to 14, suggesting a mild disability. And lastly, only 1.19% of people had a score of 15 to 24, indicating moderate disability. There are many methods in which you can calculate a neck disability index, and one of them is showed here below, through driving. And the grades ranged from driving a car without neck pain, which is grade 0, to inability to drive a car at all, which is grade 5. My message to you, it's simple. Just be aware of your body. Take regular breaks. Raise your device to your eye level. Keep your legs flat on the floor. Try to keep your head in a neutral position. Sit up straight. Roll your shoulders. You can even lay on your back to relieve that pressure on your neck. And thank you very much for listening.
Assalamu alaikum. My name is Ibrahim Haddar, a fourth year medical student at the Libyan International Medical University. Many diseases have the tendency to be more common in a specific gender. One difference that really stands out is that of autoimmune diseases, where females are much more likely to suffer of them, some reaching rates as high as 85 to 95%. In this poster, we shall discuss the possible causes that could explain the difference in distribution. But before going into that, we shall first go over a brief introduction about the immune system. The immune system is the part of the body responsible for protection from foreign invaders, and also from internal problems, such as neoplasms. it is seen as having two main branches consisting of two different responses: a non-specific innate response, which is also the early response, and a more potent adaptive response that takes a longer time to be activated. An important aspect of the immune system is its tolerance, meaning that the immune system is unresponsive to the body's self-antigens. This explains why the immune system does not attack our own body under normal circumstances. The loss of tolerance is what underlies autoimmune diseases, and the main step of losing tolerance is the activation of self-reactive helper T cells, also called CD4 cells. Here, the term self-reactive means that the cell shall react with a body antigen. So before talking about the possible causes of variation in disease rates, we shall first discuss the biological differences between males and females that could help us explain the difference in rates, mainly focusing on the genetic and hormonal differences. Genetically, males have the X and the Y chromosome, while females carry two X chromosomes. The hormonal difference is that in males, the main sex hormones are the androgens, such as testosterone, while in females, the dominant sex hormones are progesterone and estrogen. Now we shall see how these two differences, just mentioned, could help explain the difference in distribution of autoimmune diseases. So immune cells carry receptors for all three sex hormones. Both the androgens and progesterone show an anti-inflammatory effect. However, estrogen was found to show a pro-inflammatory effect and increases both the humoral and the cell-mediated immune response. The effect of the X chromosome in the immune system is well established, and it is known to carry many genes important for immunity. This also explains why females have a stronger, more effective immune system. However, this can be described as a double-edged sword, as it is also one of the possible reasons why females are so much more likely to develop an autoimmune disease. In conclusion, it is safe to say, while that autoimmune diseases are more common in females, the exact cause is still unknown, and it's likely to be a variety of factors contributing to it. Now, before I finish, there is one point I must mention. The topics of pregnancy and menopause were purposely avoided, even though they have a direct effect on autoimmune diseases. This is because there is a lack of available studies and no real figures were available for me to use. Thank you, and I hope you enjoyed.
السلام عليكم، أنا اسمي حليمة بشيحة، طالبة في سنة 4 بشري في الجامعة العلمية الدولية. موضوع البوستر بتاعي How does our brain GPS work, or how we navigate and collect spaces. The Nobel Prize in Physiology and Medicine in 2014 was awarded to John O'Keefe for discovering special cells in the brain called the place cells, and for Maybert and Edward Moser for discovering another type of cells in the brain called the Grad cells. Both place cells and Grad cells form a positioning system in the brain أو اللي هو يسمى فيه inner GPS. حاليا يعتقدوا أن السيستم هذا or these cells هن المسؤولات على أن كيف الشخص يعرف المكان اللي هو فيه شنو أو المسافة من مكان لآخر هكذا. Materials and methods. The data on this poster was collected from two different studies. The first study talks about John O'Keefe experiment or the place cells, and the second study talks about the Moser's experiment or the Grad cells. Both studies were performed on rats and there was no human trials. The first experiment by John O'Keefe in 1971. As I mentioned earlier, both studies were performed on rats, so the rat was allowed to move freely in a bounded area. He noticed that certain nerve cells were active when the rat reached a particular place in the environment. He called these cells as place cells and the environment as place field. He also noticed that these cells are located at the hippocampus, that has a major role in learning, memory, and emotions. So he claimed that these cells has a memory function. The second experiment by Maybrit and Edward Moser in 2005, they explored the presence of place cells but outside the hippocampus, بالضبط وين في الانترانal cortex, بحيث أن certain nerve cells in the entorhinal cortex were active when the rat reached a particular place in the environment. They called these cells as grid cells because of their unusual firing pattern اللي هو كان hexagonal shape. So as we see in figure 3 picture C, a single grid cell fires or gets activated when the rat reaches a particular location in the environment. These different locations are arranged in hexagonal pattern. They concluded that these cells in the entorhinal cortex with the place cells in the hippocampus constitutes an inner GPS in the brain. Different investigations have provided that place and grid cells exist also in humans. مش بس هيك لقوا أن حتى patients with Alzheimer's disease لقوا أن hippocampus and entorhinal cortex are mainly affected at early stages. So better understanding of these cells and their mechanism of action may help us in understanding the pathophysiology of Alzheimer's disease and its treatment. In conclusion, place cells, grid cells, head direction cells, and border cells are involved in creating spatial maps in brain that enables a sense of place and navigational ability. Understanding of the brain positioning system may help us in the treatment of brain disorders like dementia and Alzheimer's. These are my references and thank you.
Assalamu alaikum, my name is Aman Al-Ghul. I am 4th year medical student. My topic is about how affects systemic lupus erythematosus on kidney. What's the systemic lupus erythematosus? An autoimmune disease in which the body immune system mistakenly attacks healthy tissue in the body and affects multiple organ and body system. SLEI can specific for joint disease such as rheumatoid arthritis. تميز بأنها multiple organ affected level of all body. هيكون معها autoimmune antibody and anti-DNA antibody. Etiology, the exact cause of SLE isn't known, but several factors have been associated with the disease, include sex hormone, بأنها هي most common في female because it is possible for him to have relationship with estrogen. Environmental triggers can include ultraviolet rays. تلاحظ كلمة تعرض للالترافويلت تحتها precipitating factor إنه هو حتجيه الأتاك. Other people قالوا induce damage معين في DNA hence للاميون complex. ممكن drugs, physiological or emotional stress, trauma, and genetic. The disease isn't linked to a certain gene, but people with lupus often have family members with other autoimmune condition. Symptoms between people may be mild to severe. قال لك ان هي مالتي سيستم. اول ما تشوف البيشنت راح تلقى انه هو prolonged fever ممكن يجيب CNS manifestation كيف neurological or psychiatric manifestation راح يصير لهم الالوبيشيا. اشهر حاجه في اللوبس انه هو butterfly area ممكن generalized lymphadenopathy. heart problem راح تلقى pericarditis or myocarditis. reaction على السبلين حنلقوا splenomegaly. على اللنج pleurisy or pleural effusion. على الكدني ممكن تلقى acute or chronic glomerular nephritis, nephrotic syndrome وتنتهي بالrenal failure. ممكن تصير arthralgia, fasciculitis, ممكن تحصل hypercoagulopathy. Effect of SLE on kidney. When SLE attack a kidney, it causes disease يعرف باللوبس nephritis, which results in nephritis. The smallest unit of kidney that filter blood from waste products, toxic substance, exceeds a fluid and salt and excrete it out of the body through urination. And SLE that impairs kidney from function and accumulate the substance that must be deposited naturally in the body, causing many symptoms include a blood in the urine, an increase of protein in the urine, hypertension, a swelling in your hand, ankle or feet, high level of creatinine in the blood. Methods in this study collected data on the clinical and immunological feature of SLE reported from 11 different Arab countries. Data were collected at Jordan University Hospital, Department of Medicine between August 2016 and August 2017. Family history of SLE was present in 8.3%. Discussion analyzed data on 3,273 patients. Majority of patients were from Saudi Arabia 39% and Tunisia 30%. The remaining 29% were from 9 other countries. The common clinical manifestation was arthritis or arthralgia, following by anemia, fatigue, malarial rash, and renal manifestation. Most patients were positive for ANA, while anti-DNA was presented in 3 quarters. لما شافوا كل دولة طبقوها بروحها فشافوا a voice difference between country in relation to the different manifestation. This fever was very rare in Tunisia, 2.1%, and common in Yemen, 81.9%. Malarial rash was common in Egypt. Discoid rash was very uncommon in Sudan. Photosensitivity was less common in Lebanon and most common in Egypt. Alopecia was very rare in Tunisia. Oral ulcer was common most in Egypt. With the exception of coital manifestation were common in all countries, 54.4%, and neuropsychiatric manifestation effects, thirds of patients are from Oman, Egypt, and Tunisia. Cardiac manifestation were common in Iraq and Tunisia and rather uncommon in Kuwait. Hemolytic anemia was uncommon in the Arab world, ranging from 4.8 to 13.8%. The exception was Tunisia, where hemolytic anemia was reported in over half of the patients. This interstate difference may be due to heterogeneity of the Arab peoples. This figure shows frequency of systemic lupus erythematosus manifestation in Arab world. The commonest clinical manifestation was arthralgia or arthritis, which occurred in 81.1%. Other common manifestation includes anemia, 55.6%, fatigue, 53.4%, malarial rash, 53.1%, and renal manifestation, 50.4%. Conclusion: there should be health education regarding the negative impact of disease active on the patient, help physicians to understand and to provide better support to SLE patient besides rapid meticulous control of disease activity. Finally, these are the references.
وتوا حنكون مع فقرة الريسيرش سمري.
Modern medical advances in knowledge help millions of people live longer and healthier lives. We owe these improvements to decades of investment in medical research. This is an important and powerful quote that highlights the importance of investing in medical research. So on that note, السلام عليكم. اسمي يارا مسعود التهامي، طالبة في سنة 5 في كلية الطب البشري. And today I want to talk to you about the researchers that were published from the Department of Surgery in Libyan International Medical University. I have 2 published papers that I want to summarize and highlight their content of. The first paper was published on the 14th of November of 2019. It was titled Hospital-Acquired Surgical Site Infections at Al Jala Teaching Hospital, Benghazi, Libya. This is a very important topic to research about, seeing how surgical site infections are the 3rd most commonly reported nosocomial infections that affect about 2 million people each year around the world. And it has significant repercussions on patients' health and significant financial effect as well. So the main purpose or the main objective of this paper was to find out the prevalence of the surgical site infections, identifying the associated risk factors, and knowing the organisms involved. So the main method that was used was a descriptive case study at the Department of Surgery in Al Jalal Teaching Hospital in Benghazi, Libya. So the data that was collected from a total number of 204 cases who underwent surgery in 2018. Their data was collected retrospectively and analyzed accordingly. The results that were found indicated that out of the 204 patients, 14.7% were infected post-surgery. And the most common bacteria that caused surgical site infection was found to be Staphylococcus aureus. And concerning the risk factors, 4 were mainly identified as being associated with surgical site infections. 1, the prolonged operative time of the patient. 2, the extended hospital time of the patient. 3, the urgent nature of the surgery, and 4, the presence of anemia in the patient. So in conclusion, it was found that the infection rate was higher than that of a developed country. The risk factors were in fact present and identified to have a significant association with an increase in the rate of the surgical site infection, and that Staphylococcus aureus was the most common organism isolated. And thereby a list of recommendations were given for the hope that further research would be made on this matter. So a special thanks should be given to Dr. Uthman al-Tajuri, seeing how this paper was published by him in the Journal of Surgery and Insights. So now moving on to the second paper, it was published on February 22, 2018. It was titled Patterns of Abdominal Injuries Resulting from Sharpening of the Muscles, Cases Admitted to Benghazi Medical Center. See, abdominal trauma is considered one of the most common traumas seen in emergency departments worldwide. And currently in our city, Benghazi, the majority of abdominal injuries are related to sharpening of the muscles. So this is a very important topic to talk about and make researchers in its field. So the main objective of the study was to evaluate 1, the clinical manifestations, 2, diagnostic approaches, and 3, the management of different organ injuries. And 4th, knowing the morbidity and mortality that were caused by the sharpening of the muscles. So we have 4 main areas to tackle. The method that was used in this paper was a retrospective study of the medical records of 100 patients presenting to the emergency department with a history of abdominal trauma in Benghazi Medical Center. So from the time period from January 1st, 2016 to 31st of December of 2016. So the duration was a year. So what was found, or the results, were that patients ranging from 4 years of age to 50 were prone to this type of trauma more, and males were predominantly involved. And the results found concerning the clinical manifestations indicated that abdominal pain was the most common presentation and abdominal tenderness was the most common sign. Concerning the diagnostic modalities, it was found that abdominal ultrasound was 81% sensitive and 100% specific in diagnosing solid organ injury. And concerning the management approaches, operative management was done in 85% of cases, and it really should be noted that the mean duration of hospital stay for operative cases was 20 days, and for non-operative cases it was a total of 7 days only. And finally, or lastly, the mortality rate was found to be 7% overall. So, in the end, I want to give a special thanks to Dr. Muhammad Neji, seeing how this paper was published by him in the 4th Annual Congress and Medicare Expo of Trauma and Critical Care in Paris, France. So a very special thanks should be given to both Dr. Uthman al-Tajuri and Dr. Muhammad Neji. And thank you all for listening, and bye.
مجموعة من الأنشطة اللي قام بها طلبة وطالبات كلية الطب البشري، خلونا نعاد نشوفوهن ونرجع من جديد.
كفجر نزيح الظلام فكنا الضياء بشمس فتيا وجئنا الطبيب لنمحو السقام، فنحن بني الجامعة الدولية أتينا كفجر نزيح الظلام، فكنا الضياء بشمس فتية. وجئنا الطبيب لنمحو السقام، فنحن بني الجامعة الدولية شبابا ونرفع راية العلوم، ونخطو بها من يفوق الثريا. شبابا ونرفع راية العلوم، ونخطو بها من يفوق الثريا. فنحن القدوم ليوم القدوم، ونحن الأمام لليبيا الأبية.
السلام عليكم، أنا الطالبة آية عامر، طالبة في الجامعة الدولية كلية الطب البشري سنة رابعة. اليوم حابة نحكي لكم شوية عن تجربتي في الدراسة عن بعد، اللي أنا أصلا بصراحة ما كنتش مقتنعة بها. يعني كنت نقول كيف تبي تعوض محاضرة كنا نمشوا فيها للجامعة، كنا نسأل في الدكتور ونقدر نرفع يدينا في أي وقت ونسأل، وكنا نستفيدوا من أسئلة بعضنا. بس بصراحة بعد جربتها كانت تجربة حلوة بكل، خصوصا نحكي على الكيس سيناريو اللي كانت الجامعة موفرة برنامج اسمه الزوم، كنا نقدر نشوف الدكتور نسألوه في أي لحظة، وكنا كلنا نستمعوا لبعضنا ونستفيدوا من أسئلة بعضنا.
كل عام وأنتم بألف خير، ينعاد عليكم بالصحة والسعادة. أنا هند خير الرفاعي، طالبة سنة 5 بشري بالجامعة الدولية. رح أحكي عن distance learning أو distance educations أو online classes يلي جامعتنا الوحيدة بليبيا كانت عاملة هالشي. أنا كتير فخورة بجامعتنا بأنه عملت هالشي وما ضيعت علينا أشهر من أنه قاعدين ما عم نعمل شي بالبيت. طبعا كل الليكتشرز كنا نحضرهم على الزوم، برنامج الزوم. الجامعة وفرت لنا إيميلات مخصوصة مربوطة بالجامعة عشان لو أي مشكلة صار فيها نبلغ الجامعة. وبعدين انتقلنا على برنامج تاني اللي هو الجوجل ميت. من المميزات يلي أنا كتير انبسطت فيها إنه المحاضرات بتكون مسجلة بصوت الدكتور، والمحاضرة قبالك بنزلوها على اليوتيوب بقناة الجامعة الخاصة فيها، وفينا نرجع للمحاضرة بأي وقت بدنا إياه. فكانت هاي ميزة كتير مهمة. يعني لو أنا انقطع عندي الإنترنت أو انقطعت عندي الكهرباء بنص المحاضرة، فيني أرجع أشوف المحاضرة مرة تانية على اليوتيوب. الدكاترة كانوا كتير متعاونين معنا، يعني بس يشرح الدكتور المحاضرة، لو نحن عنا أي سؤال كنا نرفع إيدنا ببرنامج الزوم أو نكتب للدكتور تحت إنه دكتور نحن عنا سؤال ومش فاهمين. بالعكس كانوا كل الدكاترة كتير متفاهمين، وبالعكس كتير عجبتني الأونلاين ليكتشرز. بالأونلاين ليكتشرز ما في عجقة، ما في صوت طلبة عم يحكوا حدك أو ما مخلينا مركزين بالمحاضرة. كتير رواق، الدكتور بس هو اللي عم يشرح ونحن مركزين معه بالمحاضرة معروضة قدامه. شي كمان كان كتير حلو وكتير عجبني هو الكيس سيناريو. لما كانت تنزل قبل ب3 أيام تنزل، نحن منجهزها وكنا نشارك مع الدكتورة ونحضرها، الدكتور والدكتورة اللي كانوا معنا. فكانت كتير حلوة وكتير سلسة وبتمشي بطريقة كتير حلوة صراحة، أحلى من الواقع صراحة. كانوا كل الدكاترة متفهمين بقصة الإنترنت وقصة الكهرباء، فكان لما بدهم ياخدوا حضورنا ويكون طالب مش موجود، فالطالب يبعث لهم مسج إنه الكهرباء عنده مقطوعة أو ما عنده إنترنت، فهن يعرفوا هالسبب وما يسجلوه غياب، لأنه هالأشياء خارج عن إرادتنا. فالجامعة كانت كتير متفاهمة لهالشي. حتى بأنه دفع الأقساط كانوا كتير متفاهمين. كل اللي بحكي خارج البلد وبحكي لعائلتي برا أن أنا عم أدرس أونلاين، كلنا عم يحكوا واو نحن هون ما حدا عم يدرس. كل الدول بأوروبا، بأمريكا، بكندا، بكتير دول ما عم يدرسوا أونلاين، بس نحن بليبيا هون بنغازي تحديدا الجامعة الليبية الدولية درسنا أونلاين وما ضيعنا فرصة. وأنا هلأ خلصت ميديسن 2 تقريبا، وإن شاء الله رح نبلش بعد العيد بالجامعة. بس بدي أحكي عن تجربتي بالأونلاين. It's perfect. عن جد ما كان فيها شوائب، وبالعكس ساعدتني كتير، لأنه فيني أرجع للمحاضرة إمتى ما بدي، لأنه مسجلة عندي باليوتيوب. بشكر كل الدكاترة والكوردينيتر اللي كانت كتير متفهميتنا وكتير يعني بترد على مسيجاتنا بالموديل. والديستانس education أو الديستانس learning أو الأونلاين lectures مهما اختلفوا المسميات كتير حلوة، ما بتضيع عليكم وقت وبتدرسوا وانتوا بالبيت. What's better than that? Thank you.
وصلنا لختام فقراتنا لهذا اليوم، وفي الختام حابة نشكر كل من ساهم في إظهار هذا العمل بالصورة المطلوبة، سواء من إدارة الجامعة، إدارة الكليات، أعضاء هيئة التدريس، الموظفين أو الطلبة. إن شاء الله نكون اليوم قدمنا لكم كل ما هو مفيد، وبإذن الله تعالى نلتقي السنة الجاية في موعدنا، وإن شاء الله تكون الظروف مواتية وتكون الظروف أحسن. أنا غادة سليمان الشطيطي، طالبة في السنة الخامسة في كلية الطب البشري بالجامعة العلمية الدولية. شكرا.